occurs. And mind you, the germ cells really initially are kept outside of the body while all the somatic development goes on. And then in a human, in about 3 weeks, these cells that are destined to become PGCs, these germ cells, then migrate up to the dorsal ridge. But they start out right here, and we're actually recreating embryology, so these will be very young eggs. So the early epiblast cells are separated from the rest of the developing embryo, and in vitro gametogenesis just copies this early embryonic process. So oocytes generated in vitro from iPS cells will be very young. And just think about it, in the future, a 38-year-old woman might be better off having a skin biopsy than an oocyte retrieval for IVF, because these will be virtually embryonic oocytes. So we're just recreating the fetal process, and the early germ cells have been separated from the somatic development of the embryo. They have to be, because they have to retain their totipotentiality while the rest of the embryo is differentiating. And then they migrate up towards the spine, where the primordial gonad, which is located there, is either going to become a testis or an ovary. If these primordial germ cells enter an ovary, they're going to become oocytes. If they enter a testis, they're going to become spermatogenic stem cells. And so with our in vitro gametogenesis, we're learning much better how the ovary works than we did before. And this is just a diagram showing the various embryonic stages on top, and then showing the in vitro stages on the bottom, and just summarizing that you can see if these early PGCs that migrate to the early gonad, if it's going to be a male, they make sperm, and if it's going to be a female, they make oocytes. And actually, I can outline for you, it's very simple to do with simply genes that you can purchase. This is not going to be something esoteric to accomplish. So primordial follicles are actually locked by FOX3 and pressure, actually. So ovary tissue is very difficult to be cultured to an oocyte. Well, I'm going to show you at the end of this talk, now we can do that. We can culture, at least in the mouse, and we will be able to in the human eventually, primordial follicles from the ovary tissue, be able to culture it all the way to mature metaphase 2 oocyte. But what happens now is it's easier right now just to make oocytes actually from somatic skin cells and iPS cells than it is from the ovary tissue, because the primordial follicles are really locked, and they've been very difficult to unlock until just recently. So we make skin cells to iPS cells in 3 to 4 weeks, culturing in these 4 genes, and then iPS cells to epiblast cells for 2 days, just recreating embryology, and then epiblast cells to PGC-like cells, but there really are PGCs, in 6 days. And then we incubate the PGC cells with fetal granulosa cells. They can't be adult granulosa cells. Fetal granulosa cells have the factors necessary then to turn them into competent oocytes. Very important you remember these terms. IVD, in vitro differentiation. That's when the PGCs actually become oocytes. And then FSH culture, that's gonadotropin culture, IVG we call that, and that's when the differentiated oocytes actually become sensitive to gonadotropin. And then finally, just 1 day of IVM, which is culture in HCG, to turn the GV oocyte into a competent metaphase 2 oocyte. Now, this is all in the mouse, but we recreate in the human, and the time frame is obviously a little different. But understand that IVD phase, and you'll appreciate this in my last lecture of the day on in vitro maturation, that IVD phase is not hormonally sensitive at all. And in the human, it's approximately 4 months from recruitment of a primordial follicle to when it becomes sensitive to gonadotropin. And the gonadotropin phase of 11 days is the same in the human as it is in the mouse, as it is in most animals. Okay, so iPS cells can be readily made by incubating somatic cells like the skin with just 4 known genes, which can be readily purchased. And one can use just 3 genes, but all 4 originally described genes by Yamanaka gives you the best quality iPS cells. And then once you've made the iPS cells, you can maintain them in just 3 genes, no feeder layer or fibroblasts. LIF, FGFI, and GSK2B. Now, it sounds complicated, but these genes can all be purchased. Then you incubate those iPS cells in 3 different genes again to make epiblast-like cells. And the 3 genes that make epiblast cells are activin A, B, FGI, and KSR. And then the epiblast-like cells are incubated with 5 genes, and behold, you have primordial germ cells. And then below you can see the 5 commercially available genes that will finally convert the epiblast cells into primordial germ cells, or PGCs. And this is the original diagram from Hakabi et al. That I was participating in the mouse. And again, notice it's very important. You have 21 days of IVD and 11 to 14 days of IVG, that is gonadotropin sensitivity, where we've added FSH to the media. And it's very simple media, except that it has FSH in it. And then finally 1 day of IVM, and a little FSH is necessary to get the proper maturation. So you don't need only HCG, you need a small amount of FSH as well. And this is just another diagram just showing you comparing in vivo development from the original ICM to epiblast to PGCs. And below that is the in vitro recreation of what happens in vivo. And you can figure out what genes to incubate with just by doing reverse transcriptase. This is all about transcriptase or transcriptome arrays. And you can just take the transcripts that you find in the different embryologic stages in any animal and do a reverse transcriptome and find out what genes you need to incubate these cells with. And it turns out to be a very sparse, small number of genes. But keep in mind, differentiate between IVD differentiation, which is not hormonal, IVG, which is hormonal sensitivity, and then IVM, which is the LH or HCG sensitivity. And this is just, again, summarized. I'm repeating myself, I guess, because I just think it's important for you to understand these early phases. It's very, very robust, and anybody can do it because you can purchase these genes. And if you understand IVD, IVG, and an IVM, then doing IVM in human ovary tissue becomes relatively easy. So here are the PGCs that are mixed with fetal granulosa cells, and then they have to be separated after those 3 weeks so that they can be so that the FSH can actually reach them. And you see these are very, very nice GV oocytes that are now exposed to FSH, and then will be exposed to HCG. And these are the first iPS cell-derived mouse pups derived from the skin fibroblasts of their mother who had no ovaries. So in vitro production of oocytes from skin helps one better understand the ovary. In vivo, 4.5 months after recruitment, the cells have gone through IVD and IVG, just like in vitro, and are ready for IVM. And this is a constantly changing daily dynamic. Oocytes that were recruited less than 4.5 months earlier are still going through IVD or early IVG. In vivo, once the oocytes have completed IVG, they are meiotically competent and ready for HCG or the LH cert. This is a constant daily process, so at any time a certain number of oocytes in the in vivo ovary have completed IVG and are ready for IVM, and it's relatively easy to do. When you are puncturing the follicles to try to get these GVs, the results are not going to be nearly as good as if you actually are dissecting the ovary tissue, and I'll explain that later this afternoon. But the summary of this whole process, you'll understand everything I'm going to say in the rest of this talk if you just take a look at this diagram. IVD in the human occurs for about a 4-month period after recruitment from primordial follicle. And there is a magic 11-day period of IVG when the follicles have just finished their differentiation, are sensitive to gonadotropin, and if they're exposed to 7 days, at least 7 days of FSH, then they will have meiotic competence. If they're exposed more than 11 days to FSH, they will just degenerate because they're post-mature. And you can see this phenomenon even when you do ovarian stimulation in vivo. So there is this sweet spot of 4 days, between 7 and 11 days of exposure to FSH, that gives you competent GVs that will turn into M2s, and that's a 35% maturation rate, and that's what you find with in vitro maturation. 35% of these GVs will mature. So actually, philosophically, you don't need ovarian stimulation for oocyte maturity. In vivo FSH has already created GVs with meiotic competence, and you do not even need normal ovulatory cycle for meiotic competence or for GVs. You only need ovarian stimulation or the ovulatory hormone cycle for follicle enlargement so that you can get the egg out of the ovary. It really isn't necessary for maturation. That's occurring anyway. The only reason for follicle enlargement is so that you can get the egg out of the ovary. So this is the team that I work with in Kyushu, Japan. You can see we jokingly refer to Katsuhiko as the X chromosome and me as the Y chromosome. I'm shorter than every Japanese person in that picture. So what started all this is very, very interesting. How did we get into this? I'm a microsurgeon and interested in transplantation. So how did this happen? Well, we had an unusual series you've all heard about of identical twins discordant for ovarian failure who underwent the first ovary transplants. And this is an example of one of those 10. And so Crystal's eggs were quite fertile even until 46 years of age, which was quite remarkable. But Bonnie was born with no eggs. So how could they be identical twins, and yet one has a normal component of eggs, an extra component of eggs, and the other one, Bonnie, was born with no eggs? We wanted to understand that. But there was a deeper question. If the reason for discordancy of ovarian failure in identical twins is not genetic or epigenetic, but is misallocation at the time of splitting, we could determine in the human embryo when germ cell specification occurs just by the obstetric history. So if we could generate the germ cells from skin biopsy, that would rule out an epigenetic or genetic error causing POI, leaving the only explanation germ cell misallocation at the time of splitting. Now, there is Bonnie after her transplant with her 3 kids, the last one born when she was 46, and therefore the ovary from her sister was still 46 years old, and all 3 of these were spontaneous pregnancies with no IVF. But now, at age 55, we're making germ cells for her from her skin biopsy. And we simply at St. Louis just do a simple skin punch biopsy. It's not very invasive, but it took a huge amount of effort to get IRB approval, both at UCLA and at St. Luke's. And we were able to actually produce competent PGCs from 55-year-old women with their skin cells. And this is the paper that was just published, the detailed paper, just published last month, actually, in Cell Reports. And it took a long time because it's very controversial, but we did every kind of testing we could on these on the PGCs, and they were all just completely normal PGCs. And this was the summary of Cell Reports, the diagrammatic summary, how we were able to do this in vitro with these women. But we've also done it with men. So we just as easily are able to make PGCs from azoospermic men. And so the question is, where do we go from here? How do we make the PGCs turn into oocytes or turn into sperm? And now we know how to do it. So the paper, Pandolfi et al. Was the grad student, and I'm just summarizing that the genome sequencing demonstrated that the lack of germ cells in the infertile twin was not due to a genetic barrier, but really just to misallocation. I'll go through these words and just go to this slide. So we knew, therefore, that it was misallocation, and since all of these identical twins discordant for ovarian failure were monochorionic and monoamniotic, which is splitting between days 9 and 12, we were able to discern for the first time that germ cell specification in the human embryo occurs between 9 and 12 days. And that was, no one ever dreamed we'd be able to find that out in the human embryo. So now we can skip these early steps with just 8 core genes. Now, there are many downstream genes, but just 8 core genes in the mouse can, with granulosa cells, non-gonadotropin sensitive, makes primary follicles that are FSH ready. So we know that, but it's IVD. And then FSH culture and IVM culture is relatively easy. But let me go into this transcriptional factors of 8 core genes by Hamazaki et al. This is all from our group in Japan. So these are the 8 core genes that all you need, this is all you need to convert primordial follicles into normal oocytes that are capable of maturing to M2 oocytes. Now there's many downstream genes involved, but these are the core genes that trigger all the downstream genes. It's like SRY. SRY does not construct the testes, but triggers many downstream genes all over the genome that do. And that's the same as the case with these 8 core genes. They're the only transcripts you need. So they recruit primordial follicles to grow directly into secondary follicles ready to respond to gonadotropin. And that's all you need to unlock primordial follicles and let them develop to the IVG stage. Now you should note that the primordial follicles have already gotten through fetal granulosa cell stage. So they have meiotic competence, STRA8 induced. They have undergone erasure of imprinting. So primordial follicles can be mixed with PPT8 genes and make normal oocytes. But you can't do that with iPS cells. If you incubate them with stem cells, you get oocyte-like cells. And in fact, when you fertilize them, they cleave to the 8-cell stage, but they don't go beyond 8-cell because there's no meiosis and no imprinting, which would normally occur with exposure to fetal granulosa cells. So the PPT8 genes are great for maturing primordial follicles, but they're not going to be adequate for iPS cells. So you differentiate that between PPT8 and diol. And this is just a summary that if they're already exposed to granulosa cells, then all you need is these 8 genes to finish the project. But what we're interested in is how we can turn PGCs into oocytes that have not gone through the primordial follicle phase and have not been exposed to granulosa cells. I'm going to go quickly because I don't want to overrun my time. And I've got a lot of explanations here, but let me go to the solutions for the human. So we want to duplicate what fetal granulosa cells secrete to transform PGCs into oocytes, because adult granulosa cells won't do it, and we were not going to try to get fetal granulosa cells from abortion clinics in America because we'd probably be picketed and we certainly wouldn't get approval to do it. So we still use the 8 core genes approach with reverse transcriptome of embryonic development from epiblast to somatic ovary cells. Not epiblast to oocytes, but epiblast to somatic ovary cells. And this was the famous paper by Yoshino et al. Last year, again from our group, showing that using a different set of core genes, you can culture in one dish, you can culture to PGCs, in another dish you can culture the iPS cells to fetal granulosa cells, and then you culture the fetal granulosa cells you've just made with the PGCs you've just made, and you get mature oocytes. And this is just a summary of the interaction that has to occur, germ cells and supporting cells. So we induce ovarian somatic cells from PGCs, and then we reconstitute the ovarian follicles without embryonic cells being necessary. And this is a diagram of the different stages of embryonic development from left to right on top that we got transcripts for, and we use those transcripts to make fetal granulosa cells, not just oocytes. Okay, wait a second. Yeah, here's a picture. You can see at the various stages generation of ovarian follicles from mouse pluripotent cells. There are the mouse babies. Again, we didn't have to obtain fetal somatic cells or granulosa cells from other mice. We generated in one culture system the PGCs. In another culture system, we generated the fetal granulosa cells, all from skin, and then we mixed the two together for the usual 3 weeks in the mouse, and we got competent oocytes. So, conclusion, our results demonstrate that functional fetal gonadosomatic cells can be induced from embryonic stem cells through a faithful differentiation process in culture. The generated material will serve as a useful source to replace embryonic ovarian tissue for in vitro gametogenesis. So functional oocytes can be produced without the need of embryonic tissue, and this is applicable to any mammalian species. And so we're, of course, working on this in the human. We have human PGCs. We predict that within 5 years, we'll have human fetal granulosa cells developed from skin biopsy, and we'll be able to make oocytes, the competent oocytes, and they'll be very young competent oocytes. This is being applied to endangered species. Already the northern white rhino has gone extinct, but we have their skin. And we've already made stem cells, and we're in the process of making oocytes from the skin biopsy of these northern white rhinos that have gone extinct. And this is just a diagram of, again, what I was just talking about. PGC-like cells can be reconstituted in follicle-like structures, and then you have follicular development, oocyte growth, and a healthy, normal baby mouse. Again, that's the picture of the team working together, and I showed you earlier the picture of Amanda Clark, who in her lab at UCLA is translating this to the human. This is also the basis for understanding now how we can successfully do, robustly and easily perform IVM. At the same time, we remove an ovary for ovary tissue freezing. So thank you very much for inviting me here.
Thank you very much for your nice presentation. Any question from the floor, please? What is the benefit, please, of the skin-derived stem cells over the normal stem cells for what is the benefit of stem cells, skin-derived stem cells? Why are they beneficial more than the regular stem cells you can obtain from any other part of the body?
Skin just seemed very easy. We use the fibroblasts from the skin, actually, but any somatic cell can be used. In fact, you can even get urothelial cells from the urine. That's been done. iPS cells are made just from a urine sample. So the skin isn't necessary. It's just what we were using. But any somatic cell that you have easy access to will work the same way.
Another question. This ability of somatic cells to produce oocytes by developing in vitro is related to the reproductive age of the donor?
I apologize for my bad hearing. So I'm 81 years old. The question was, what if we have this older woman at 55 years old, or an old mouse, or even older than 55? Now, what happens when you convert their somatic cells to iPS cells or stem cells, you're literally making the cells younger. Now, there will be mutations, but you make so many of these cells that you can easily eliminate the cells that have the mutations. And that's what we had to do even to get this paper published. Eliminate the cells that had the mutations so that we had pure, young iPS cells developed from 55-year-old women.
Thank you very much, Dr. Silver. Thank you. And now is the time for Dr. Sayanglin Dan. Is he around? Okay. Sang Lin Tan? Yeah. Yeah. He is currently a full professor of Obs and Gynae and holds the James Edmund Dodd Chair in Obs and Gynae Department, McGill University. He is the founding director and the medical director of Origin L Fertility Center and Women's Health Center, Montreal and Ottawa.
Thank you, Mr. Chairman.
The topic will be on oocyte vitrification for medical and social reasons.
Thank you, Mr. Chairman. Firstly, I'd like to thank Professor Gamal Sarwar and the organizing committee for inviting me here. Like Sherman, Egypt is really one of our favorite cities. And in fact, my son, whose birthday is tomorrow, is flying all the way from Canada to join us to celebrate his birthday here. The second thing I want to say is that it's a daunting task for the rest of us during this session to speak after a lecture like what Sherman Silber gave. Because frankly speaking, I think in the world today, there's only one Sherman Silber. And every lecture he gives really is an absolute world-class lecture, but we'll do our best. So what I'm discussing today is basically how to preserve fertility for medical and social reasons. And although as doctors and scientists, the medical reasons are important, in a way, the social reasons have a much wider implication. Now, we should remember that there are very few areas of science or medicine that affect the whole of humanity. And one of that areas is we as OBGYN who introduced the use of birth control pill. For those of us who are old enough and remember the days before the advent of the oral contraceptive pill, life was quite different. Women's places, whether it was in the West, in the Far East, primarily revolved staying at home and looking after babies. And the relative position of women and men were totally different. It was only with the revolution of the advent of the pill where women started going out in the workforce, became better educated, and a lot of good things happened. I think it was all for the better, but the price that women and society paid is the delay of childbearing, which has led, as you see later on in this lecture, to actual decline of population in many Western countries. And this obviously has a bearing on humanity, because our first duty as human beings is to procreate and reproduce ourselves. So I'll discuss briefly the decline of female fertility, the lack of awareness and the importance of public education, even in major Western countries, the need for fertility preservation in cancer and other conditions, how I think the future may lie with the developments of technologies like what Sherman just mentioned, because at the moment we're just freezing eggs with ovarian stimulation. But that imposes much greater impediments on its use to the world. So this is a brief map of the world. Notice that the countries in yellow, the United States, despite Trump's rants and ravings against Mexican immigration, is kept stable in population because of immigration from the Caribbean and South America. And parts of the Middle East also are stable in yellow. Much of the Western world, whether it's Canada, Australia, Britain, Europe, even China or the Soviet Union, now is facing a decline in population. And it's only sub-Saharan Africa that's rapidly gaining in population, but obviously with dire socio-economic circumstances right now. The map on the right is the one that's most worrisome. It shows clearly that in 1860, at the time of the Meiji Revolution, Japan had a population of 40 million people. But the majority of people were the working age with a small retired group and still a significant number of people who were young. Over the next 100 years, as economic development occurred in Japan, the population of Japan mushroomed from 40 million to 160 million. But still, the majority of people were working to support a minority who were aged and a small number who were young. But now there's an actual decline of population in Japan, primarily because Japan is a very insular country and there are very few immigrants who go to Japan. As a result of which, by the end of this century, Japan's population will fall back to roughly where it was 200 years ago, for about 40 to 50 million people. But the difference now is that the majority of people will be retiring. And there'll be a very small proportion of people who are young or who are working. And this is a serious demographic crisis that will hit Japan like a tsunami. And I'm sure it's just a pattern to come for other countries. I was giving a lecture in Greece a few weeks ago, and I was surprised that Greece too now is facing the actual decline of population, that for the first time in their last 500 years of history, their population is dropping below 1 million. And if you do this way, so because of that, I'll show you a slide I'll look at afterwards, the actual proportion, number of people in Europe itself is declining. Obviously, some countries are more worried than others. For example, Russia, with Putin in charge, is always worried about its importance as a global power, and he realizes that the strength of a country to some extent depends on its population size. In Russia, the population was declining for a while, and therefore, because of that, they have now introduced all sorts of honors and rewards for people to have more and more children. But it's not always successful. So my interest in this area, in fact, started at the beginning of my career when I had the privilege of working together with Stuart Campbell in London, who was one of the fathers of ultrasound, Howard Jacobs, who first described polycystic ovarian syndrome, and obviously the father of us all, Bob Edwards, where the four of us together ran the London Women's Clinic in the corner of London. So, as you know, unlike men who produce new sperm all their lives, that's why Pierre Trudeau could have a son when he was 70 years old, Charlie Chaplin 80, and more recently Bernie Ecclestone, the owner of Formula One, almost at 90 could have a child just because he was married to a young lady. Women don't produce eggs until hopefully one day Sherman gets his act together. But until the present time, women don't produce eggs. And therefore, like in other parts of evolution, the best eggs come out young. And therefore, as the woman gets older, the chance of getting pregnancy becomes lower and lower. So here is a slide that we are all aware of, that basically with increasing age, the fertility rapidly declines, miscarriage rates rapidly increase, and the risk of Down syndrome or other abnormal babies rapidly rises. Now, in 1992, Bob Edwards and I published the first paper looking at cumulative success rates of IVF after repeated cycles. And we showed even then that IVF was one of the few techniques where success rates in younger women exceeded that of women who had no such problems. There's spontaneous pregnancy in fertile women. But the price we paid then obviously was a higher risk of multiple births and higher risk of ovarian hyperstimulation syndrome. Since then, obviously, now why do I show this slide? Because a sea change occurred in Canada in 2009, when after 2010, a single embryo transfer was mandated. So obviously, any results in Canada, you have to compare before 2010 to after 2010. So in 2009, the last year when you were allowed to do a double embryo transfer, the live birth rate per cycle for women who were young was about 48%, and those who were older had dropped to about 35%. In the next few years, despite a single embryo transfer, by the introduction of PGT-A and so on, success rates continued to improve. But now the biggest problem was how do you reduce the risk of OHSS? And whether you do in vitro fertilization, in vitro maturation of eggs or whatever, it makes little difference in terms of combating the increased aneuploidy rate with increasing age. So therefore, the whole purpose of preserving fertility for social reasons is to keep the same type of data or statistics for women who are in their 20s, for example, the fertility rate of 7%, Down syndrome rate of 1 in 1,000, over 1,000, and so on, until you're in your late 30s or early 40s. Now, the causes of delayed childbearing today are known to us, but it is still important to remind ourselves that the first was the advent of the birth control pill. Second is no partner waiting for the right partner. And this is very important because, as we may be aware, historically, women tended to marry either men who were of the same educational level or who had a higher education level because they depended on the men to earn an income. And even today, when most women, in fact, are able to earn the same, if not more than men, there's still this, I think, psychological, subconscious desire by most women, not all, certainly, who want to marry men of their same education or higher education. But now that the majority of university graduates are women, it becomes more and more difficult for them to find the right partner to have the right partner. And secondly, if they find the right partner of the same age, there's a difference in interest in having children. So many of our patients who are in their 30s, early 30s or mid 30s, they start having the stirrings of a desire to have kids because they can see their own friends getting children, getting married and having kids. But that's the wife. But when the man is concerned, who's 32, the man thinks, I'm a young man, there's no hurry, right? Why can't I enjoy life for the next few years and have a child in 10 years' time, right? So in caring for aging parents, because of fewer children nowadays, you've got more and more, especially in China, for example, now, with a single-child policy, you can have one child looking after 4 grandparents. So this is a big problem, right? Financial issues, health issues, and getting an education and advancing the career. So for example, the editor of Science said, a typical man has a lifetime to be a father, but the woman's reproductive prime lasts for only about a decade and coincides with the critical time for her to get a tertiary education and establishing a career. So this, for example, shows the high impact cost of taking time off. This was a review in the Harvard Business Review showing that compared to women who did not take time off to have children, women who took 1 year off to look after a child lost 11% of her lifetime income. And those who took 3 years or more off to raise a family experienced a decline of income in her lifetime of 37%. So this is the price that women pay. And I will say that it's to the benefit of society as a whole that we need to find a way that women are not made to pay the price that really is important for all of us. And this, I showed data from Canada because I happen to come from Canada, but it's everywhere in the world, right? That basically, over the last 20 or 30 years, the proportion of people who are having children are getting older and older. And yet, tertiary educated women today are just as desirous of having children as their forefathers, foremothers, many, many years ago. So you can see here that compared to women in 1974, when they went to 2 and 1, the proportion of young women ages 20 to 24 having children dropped by a third, but those who are in their late 30s increased correspondingly. Now, part of the reason is a lack of awareness. So this was a study done in University of British Columbia, which showed the better universities in Canada, and surprisingly, 20% of the 1,000 women who interviewed had the belief that fertility stayed the same from the onset of menstruation until menopause. And incredibly, 3% of the women there thought that even after menopause, fertility could be maintained. And just in case you thought, well, maybe Canadian students are a bit dumb, this is a study conducted at Stanford University and University of California in Berkeley, okay, where it showed that 63% of the students there were unaware that fertility declines between the age of 30 to 34, and 60% gives us more credit than we deserve. They believe that IVF always works, and 80% believe that exercise and diet preserves ovarian function. I'm sure like me, like you, like me, many of you have had patients in their 40s that when you tell them, I'm sorry, your AMH is low or your ovarian reserve is low, they'll turn around and say, doctor, but I eat well, I exercise, I don't drink, I don't smoke, I have a healthy lifestyle, what do you mean my eggs are no good? I mean, they're genuinely surprised. I've had patients who are lawyers, who are doctors, said, I was so busy working, building a career, I totally forgot their children. Now, why is this such a global trend? In fact, I teased Richard Kennedy just now to tell Richard, you should invite me to give a talk in Nottingham or something, but I'll give a talk. How can we use fertility preservation to preserve the white race? Now, what does this mean? Obviously, I said it tongue-in-cheek, but you can see here. So this is the data from the National Policy Institute. Even in 2008, they looked at 1950, the proportion of Asians in the world was 63%, blacks were 8.97%, and whites were 28%. In the year 2060, the proportion of the world's population who will be whites will be less than 10% for the first time in recorded history, and blacks will be 26%, with Asians remaining at 63%. Now, what does this mean? If you extrapolate this over a period of time, clearly the proportion of whites become less and less. And this is actual declines, and this was brought up by the Foreign Minister of Singapore, who was being interviewed by Newsweek to say, what did ASEAN countries think of Europe's position vis-a-vis the competition between the US and China. And he just replied, look, it's very simple. At the end of the day, what are your core interests? Are your core interests preventing Russian tanks from showing up at your doorstep in Lisbon or in Madrid or in Rome? Or is your core interest preventing masses of African refugees because of economic poverty storming up the border? He said, I think the latter is much more likely than the former. Therefore, it's more in the interest of Europe to cooperate with countries like China that will develop Africa than with the United States. Now, obviously, like other people, we started preserving fertility in women at risk of early menopause who had cancer, autoimmune disorders, etc., etc. Now, when we began this journey, Roger Gosden was working with me at McGill, and we published this first paper showing freezing of the entire intact ovarian ovary in the rat specimen, and we were able to thaw out the ovary, transplant it, and achieve live rats. But unfortunately, women's ovaries are a bit larger than the rat's ovaries, and no one has successfully frozen an entire woman's ovary. So at the moment, to preserve fertility, we have to preserve eggs, ovarian tissue, or embryos. Ovarian tissue freezing obviously was started by Jack Dornay, but many groups now, for example, that of Silbers, Anderson in Denmark, some groups in Israel now, in fact, are doing more cases than that, okay? And I said, as it is like, it'll become more useful for social fertility preservation when in vitro follicle culture becomes effective. Now, it's also been suggested that one can take a piece of the ovary or remove the entire ovary, cut it into many pieces, and then freeze it, the ovarian tissue, and when the woman turns menopausal, to then transplant small pieces of each ovary to prevent her from having menopausal symptoms. This was an idea that's been tossed around, but when I mentioned this to my colleagues, okay, some of them were worried about the potential risk of inducing breast cancer or other cancers, okay, if one were to do such an approach. Egg freezing in the old days, when I started my career, people like Christopher Chen was doing egg freezing by the slow method at the time, and survival rates were no more than 50 or 60%. And it was only with the advent of vitrification of oocytes, started off by the Japanese, okay, and then many of us modified them in different ways. So for example, we modified a device called the McGill cryolift system, and survival rates were about 90%, and today, as you know, with the best methods, survival rates are approaching 95 to 100%. Although I must add that I still think that the way future must be using automated machines, because when we quote results like 95%, 100%, even the same laboratories, different individuals can freeze results, can freeze eggs at different rates. So just like different doctors will get different success rates to embryo transfer results, even the same lab, different embryologies may get different success rates. And many centers, I think, unfortunately, are not even having their own results. They're just reporting the best results in literature and telling patients that if you freeze eggs, these are the success rates you can expect, even though they themselves may never have had a single success before, which I think is actually quite wrong. So therefore, I think that long-term, it's better to freeze eggs without using hormonal medications, like, for example, with IVM. So this was our first study on IVM, where after freezing eggs, we were able, after retrieving GV oocytes, we were able to mature about 80% of them, and after transferring the embryos, we had a 40% live birth rate. We have modified the method of IVM since then, but in the past, we used to do one ultrasound scan at the beginning of the cycle to see how many follicles there are, and the second ultrasound scan when the day of ACG to measure the thickness of endometrium, and trigger when the endometrial thickness was more than 8 mm and the follicle was about 14 mm. Since then, in fact, I've changed the protocol somewhat because I believe that it's nowadays better to transfer all IVM-derived oocytes in the frozen embryo stage. So therefore, there's no need even for a baseline scan. I would just say do a scan around day 10, follicles about 10 to 14 mm, give an injection of ACG, collect the eggs 38 hours later, and freeze embryos. But still, the success rates are reasonably good. We are able to get a clinical pregnancy rate per cycle started for about 55% or so, even up to the age of 40. But however, aneuploidy still remains a major issue. And IVF egg freezing versus IVM egg freezing, IVM egg freezing is still only half the success rate of IVF egg freezing. So the way we are doing our fertility preservation programs is that we just ask patients on the phone 2 questions. First, when can you delay your chemotherapy until? Is it a week, a month, 6 weeks, or how long? Number 2 is that can fertility drugs be safely used in your case? If they say fertility drugs can be safely used and or there's time for ovarian stimulation to be undertaken, then we will do random start ovarian stimulation, collect eggs once, twice, early follicular phase, luteal phase, whatever phase, get as many eggs, freeze the eggs or embryos as the needs be for them. But on the other hand, if fertility drugs should not be used according to the oncologist, or there's absolutely no time, we'll just collect the eggs straight away when they are immature, mature them, and then freeze those eggs. At the same time, remove a piece of the ovary, the entire ovary, and then collect the eggs from the surface of the ovary, and then freeze those eggs as well. And in doing so, we have frozen literally now, this state has not been updated for a few years. We must have now frozen eggs or embryos now by IVM by more than 500 cases of a variety of cancers. So this was the first patients that had in vitro matured egg freezing done with babies born. The outcomes were shown by Dr. Chen to be equivalent, whether you did it by IVM, IVF, or just spontaneous pregnancies. The percentage of congenital malformed babies is about 2 to 3%. So this shows freezing eggs for patients who have got lupus, who've got endometriomas, or even mothers who froze the eggs for their daughter's use. Because in this case, the mother was fertile, but the daughter had Turner syndrome. So the advantages of social egg freezing are equivalent participation by women for work. It allows women to maintain high fertility, low miscarriage, and congenital malformations as they get older. And in fact, certain ethicists have said that these are for the public good, and there should be public education campaigns, and just like breast cancer awareness or anti-smoking campaigns have been very successful in the last 20 to 30 years, a policy of encouraging women to preserve their fertility or else to start having babies when they are much younger should be undertaken across the world. The objections obviously primarily come from middle-aged, I would say white men, but in fact, I think all men in general, okay, who feel that women shouldn't have their cake and eat it, and they should still just stay at home and look after their kids first. And this is where the disparity of our approaches come in, okay? When a Trudeau or Charlie Chaplin had children when they're old, and the person who really showed how abusive the system could be was James Doonan, somebody we admire in the context of his acting. He acted as Scotty in Star Trek. He had a 7th child at the age of 80 when he was already suffering from Alzheimer's, Parkinson's, and diabetes. A few years later, he died. And the BBC, which we all respect, actually likened him to the Enterprise to say, this man boldly went into fatherhood for the 7th time at 80, where no man had dared to go before. So it's almost like this was a badge of honor and something to be praised. Whereas a woman who is 50 or 55, who starts trying to have children, people think she must be half crazy. So some ethicists in Europe have suggested that egg freezing, in fact, should be covered by the state, because after all, if a country will pay for IVF to be undertaken for its public, surely it makes more sense to preserve fertility for them when they are young than to pay for fertility treatment when they are older. This is much less successful. And in fact, Israel now is doing that, where egg freezing is subsidized and can be used up to the age of 54 years of age, because there, all treatments end at 55. So over the last few years, more and more celebrities and so on are going to egg freezing. Now, this slide is something that I think should scare all of us and our relatives, okay? It shows here at what age must people start to have children if they want to have 1, 2, or 3 kids, and whether they are prepared to do IVF. It shows here that if a family decides to have 3 children and they do not want to use IVF, they have to start having the first child at the age of 23. So we ask ourselves, how many of our friends or our daughters or our sisters are thinking of having children when they are 23? Virtually none in the Western world. And that's why, this explains why it's so difficult nowadays to have several children. So therefore, in conclusion, more and more women, despite our exhortations, are delaying childbearing. Women should be advised of the importance of declining fertility, increasing risk of miscarriage, chromosome abnormalities with increased age, and advise their children younger. And society should assist women to have children younger without affecting their careers. Social egg freezing will be increasing use in the future. IVF with egg freezing today is already having comparable results with IVF with fresh eggs. Research is still needed to improve IVF with egg freezing. And I predict one day, all women who are young will routinely preserve their fertility and create their own personal egg banks and may even will it to their daughters. And personally, I think that we should be offering treatment at cost to lead the way to the future. Thank you.
Thank you, Dr. Tan, for your nice lecture. Any questions? Okay, thank you very much.
Richard.
Now we are going to proceed to the next speaker, Professor Richard Kennedy. Professor Richard Kennedy is a consultant gynecologist and specialist in reproductive medicine and is currently medical director of the Birmingham Maternity System and honorary consultant obstetrician and gynecologist of the Birmingham Women's and Children Hospital in UK. He will address us about banana skins and how to avoid them. Welcome.
Chairman, thanks very much for that introduction, and it's a great pleasure to be here, and I want to thank the organising committee for the opportunity. It's fantastic to be doing a face-to-face meeting again, and as always, the hospitality here is great. So we've had a fantastic high-end science talk, and then we've had a really intriguing philosophical talk, and now I'm going to bring you back down to earth. So, banana skins. I've got no conflicts to declare. I've got no shares in bananas. So what do we mean by banana skins? Well, I guess many of you in the audience will be familiar with the phrase, but there is a definition in the dictionary: to make a stupid, embarrassing, or avoidable mistake. And I doubt that there's anybody in this room that hasn't made such a mistake in their clinical practice. And I'm just going to go through a few of those banana skins that we face. And of course, we have an august audience here. Many of you are really experienced, and of course, you're well past slipping on banana skins because you do know how to avoid them. But there are also those in the audience who are less experienced and have still got these joys to encounter. So, first of all, the initial assessment of the infertile couple. And there are a number of potential slips there that can be avoided with due diligence, but often are not. I just pick on a few there. Rubella immunity, for example, and with vaccine hesitancy and migration, we're increasingly experiencing people who are escaping the vaccine program. And we know the consequences of rubella infection in pregnancy. Bloodborne virus infection is another potential area of concern that might get missed in routine assessment, and of course can have consequences, and I'll look into that in a little bit more detail. Medical assessment. Are we properly assessing our patients for underlying medical conditions? We're dealing with an increasingly aging population, and there is a potential there to miss an obvious problem. And administration. So, have you ever encountered a couple who presents at your initial consultation in fertility clinic with one partner and then pitches up on the day of their egg collection with a different partner producing a sperm specimen. And of course, there's ways to avoid that. Blood-borne viruses are endemic in certain parts of the world. And we all know, of course, of the challenges of migration, particularly migration from parts of the world where blood-borne virus infections are endemic, coming into a situation where they are not endemic. So awareness of that potential in a patient that presents for infertility assessment is critical if we are to be able to manage such conditions effectively and avoid the consequences of vertical transmission. Subclinical thyroid disease, controversial area perhaps. It's probably not controversial to undertake thyroid testing routinely, perhaps more controversial to do thyroid antibody testing, but perhaps what is controversial, and there is not yet clear consensus, is the TSH threshold at which we should invoke treatment. And if we do invoke treatment, are we fully aware of the potential adverse consequences of treatment as opposed to the potential benefits of treatment? And that, I think, awaits effective trials. How many of you in the audience, I wonder, have been caught out on the day of embryo transfer or day of egg collection, perhaps, with an unforeseen and unpredicted intrauterine, intracavity abnormality? I know I have. And, of course, that is not a disaster, but it does really inconvenience the patient. The treatment has to be curtailed, alternative processes put in place. And there is a debate about routine hysteroscopy. I think that debate has probably run its course. There have been randomized controlled trials, systematic reviews, several of them, most recently by Kamath, the Cochrane review. And I think it's pretty clear that there is no benefit to be gained by a routine hysteroscopy prior to IVF treatment. I appreciate there may be some contradictory views in the audience, but that is the evidence as it stands to date. There is better evidence for hysteroscopy in repeated failed treatments. But what is less controversial and is probably now standard of care is an effective ultrasound scan undertaken prior to treatment, part of the initial assessment of an infertile couple indeed. The question, I think, is what level of ultrasound scan that should be. And of course, 2D ultrasound has limitations, and its sensitivity and specificity in detection of abnormalities is not that great. So now saline installation and 3D ultrasound in combination offers a relatively low cost and less invasive approach to getting a higher degree of specificity and sensitivity in diagnosis, to the extent that it almost equates with the so-called gold standard of hysteroscopy. And of course, a detection of intrauterine cavity abnormalities is also possible with these newer modalities. Ovarian hyperstimulation syndrome, another banana skin. Well, you'd think not, but nevertheless, it still is a banana skin, and failure to appreciate the significance of what should be easily recognizable polycystic ovaries, and failure to modify a treatment regime accordingly, and that leading to the consequence of ovarian hyperstimulation syndrome and the potential hazard for the woman's health. Indeed, mortality does occur with ovarian hyperstimulation syndrome even in 2022. So another banana skin there which can be avoided, and of course AMH and AFC provides a high degree of sensitivity and specificity in predicting the ovarian response, and therefore enabling the strategic approach to the ovarian stimulation, which can lessen the likelihood of an excessive response. And of course, we have the get out of jail card of freeze-all, and we know now that that is an effective intervention, not advised as a matter of routine, as we've heard earlier in this meeting, but is an effective approach to mitigate the risk of ovarian hyperstimulation syndrome in those women who are predicted as being over responders. The egg collection, I mean, I think today probably 2 million cycles of IVF globally, probably more now, maybe more like 2.5 million annually each year. And this data from the US, 2018, indicated the risks of egg collection is significant and finite. And we all know the proximity of the internal iliac vessels to the ovary, and the potential, particularly in somebody who is less experienced, at puncturing inadvertently a pelvic sidewall vessel. Of course, the more experienced practitioners know this very well and turn on the color flow Doppler to be able to exclude. There is a learning curve with oocyte retrieval, and the same authors in the same paper demonstrated that the likelihood of an accident, potentially serious and potentially life-threatening accident through vaginal egg collection, declines through increased numbers of procedures per operator. So that learning curve has to be gone through, and appropriate measures need to be put in place to supervise practitioners in their early stages of these procedures. So, turning to embryo transfer, and this is an ultrasound image of a highly angulated uterine cavity, but it is not that difficult to miss that diagnosis, particularly in somebody who is less experienced at ultrasound imaging, and to miss that diagnosis of the angulated canal and misinterpret the cervical canal as being the cavity. I've seen that in my own service done. Fortunately, it was picked up in time. But that is a potential hazard to an embryo transfer. And we know that the more manipulations that are undertaken, this data indicated the downward trend in pregnancy rate for increased manipulations undertaken during the process. So if you're faced with that unpredicted severe angulation of a uterine cavity, uterine canal, at the time of embryo transfer, then of course you're into a series of manipulations which are likely to deteriorate your chance of a pregnancy. And we know that the complex interventions that are often now undertaken by the embryology team, and then the last thing they want to see is a rather cat-candid gynecologist undertaking a transfer, not appreciating the difficulties that lie ahead, and then the pregnancy chance has gone as a consequence. And there are methods of improving performance in embryo transfer without inflicting the likelihood of a failed pregnancy on a woman, through the simulation procedures that have been innovated by ASRM and their partners in industry, and which are now readily available on the commercial market. And of course, if you've done that accurate ultrasound scan and predicted that there is going to be a likelihood of a problem, then the possibility of undertaking a dummy ET procedure, or at least putting steps in place to anticipate that difficulty and managing the patient accordingly. And as an aside to that, and it's not really a banana skin, But I would encourage you, this is data from one particular study. It's quite old, but it's equally applicable now. And we've all seen in our own clinics, or you should see, if you monitor the pregnancy rates per embryo transfer by practitioner, you will see differential rates, I'm sure. It's very unusual for all the practitioners to have the same rates. Of course, it is difficult because different people will be doing different cases with perhaps different challenges and so on. But don't for a minute assume that the professor and head of the department will necessarily have the best pregnancy rate per embryo transfer. So you do need to monitor the outcomes of all the practitioners and begin to challenge those whose performance in that indicator is falling below where you would expect it to be, even if that person does happen to be Professor Sarur and the august head of the service. My next banana skin is not really a banana skin because we know how to avoid it, but I will touch on multiple pregnancy because it is an avoidable and potentially catastrophic outcome. Many people believe, of course, that multiple pregnancy is a blessing. And of course, it is a blessing when it works out. But those of you in the audience who practice obstetrics, and many of you do, will understand the potential for that ending in disaster. And this data was presented in a different way yesterday, but it's the same data from the Human Fertilization and Embryology Authority in the UK. This is 219 births, and the chart reads right to left as you're looking at it. And as you're looking at it, you can see that the bars are the live birth rates on the left-hand side vertical axis, increasing over time from 1991 through to 2019, which is the most recent data. The red line represents the proportion of cases according to the right vertical axis, which are single embryo transfer. So you can see that has risen sharply, particularly in the last 10 years. And then the multiple pregnancy rate is the black line that's tracking across from your right to left, and that is now declining sharply. So what we're seeing there is, over time, increasing live birth rates, but decreasing multiple birth rates through the application of single embryo transfer. So clearly, the strategy to move to one embryo at a time is an effective strategy in eliminating largely the consequences of multiple pregnancy. Heterotopic pregnancy is relatively rare and will become increasingly so with the advent of the single embryo transfer, but nevertheless, it is still a problem. And of course, the identification of an intrauterine pregnancy, the imager will relax and think, I don't need to look at the adnexa, and miss that heterotopic pregnancy that's also sitting there. And of course, that has a potentially disastrous consequence for the woman who is sent away thinking she's got a viable intrauterine pregnancy, and perhaps she is a geographically displaced person whose access to clinical care is not so readily available, and then she ruptures her heterotopic pregnancy at 8 weeks plus with potentially fatal consequences. And this is my last banana skin, and I'm sure I've missed many, and this is the consequence of the wrong mixing of egg and sperm from the wrong partners. Now, we've had this in the UK. We've had several cases which have resulted in uncertain parenthood, which is, of course, a major disaster for any laboratory. I have no doubt that this happens with relative frequency across the globe and goes unknown. And as labs get busier and more chaotic and more patients are coming through for IVF treatment, then this becomes a real and present danger and a serious pitfall for embryology and clinical teams. And of course, there are technologies which can enable this to be avoided. How to avoid banana skins? I've touched on some of that through the talk, but I just really want to conclude with this slide. And essentially, the way a clinic runs stems from its leader. The leader will set the tone of how that clinic functions and runs and how well it functions and runs. An absolute focus on safety is paramount with a total commitment to excellence. Of course, performance indicators and outcomes need to be monitored rigorously and systematically, and don't allow complacency to set in. When you're sailing along and your results are pretty good, that's the time when you need to tighten up and concentrate and focus. For those clinics which are not doing quite so well, you need to understand what good looks like. And that means looking at your peers, looking at best practice, looking at benchmarks, looking at the best in class, learning from them, and then planning how you're going to get to good. So I think the whole issue about quality and outcomes in ART is about sharing practice, learning, but predominantly it's about the top of the organization and setting the right tone about how best we can get and maintaining that performance. So with that, thank you very much, ladies and gentlemen. Get it right the first time, please, as Hippocrates would have said. Avoid your banana skins, and happy to take any questions.
Thank you, Professor Kennedy, for your nice presentation. Any questions? Yes, Professor Abu Surur.
Gamal's going to get back at me for suggesting that his embryo transfer pregnancy rates are not as good. I didn't intend that, of course.
Thank you very much,
So-
Richard, for this excellent talk. I think this is very, very well needed in this conference. Thank you so much for that. But don't you think that one of the main reasons for getting on the banana skin misinformation which is being disseminated on the mass media, websites, and other, I will give you some examples of what's happening in this country. Like say, get two for the price of one, for having twins. Or look into the oven before you put into bread, before you put bread inside the oven, to have a hysteroscopy done. Or overstimulation to get eggs so that you produce 10 embryos or 12 embryos. This is one of the problems which you are facing, and you find that people here who are following the proper guidelines and they are not getting on the banana skin, they suffer from this. Patient would come to me after she has had embryo transfer without having hysteroscopy. Well, doctor, I didn't get pregnant. I said, well, because the pregnancy rate, I told you it is 25%. But she says, but I went to another doctor and he said, the trial failed because he did not have hysteroscopy done. That's what's happening.
Well, how long have you got? I think that, first of all, it starts from your national society and the leadership that the society and its leaders will offer to colleagues within your state. We have the same issue in the UK, the same issues everywhere. I think commercialization is driving the fertility services in the wrong direction for the wrong reasons. Perhaps that's controversial, but I believe that to be the case. I think quantity over quality is overwhelming services. Of course, there is an unmet demand for ART, so that's about public funding and moving governments to, and we've heard the arguments by SL, but getting governments to put proper funding into fertility services, so it just takes the perverse motives away from practitioners, and then driving guidelines through training, education, practice, shared learning. There's a whole basket of things that need to be done, in my view.
Thank you very much. Yes, Professor Ahmed.
Thank you for the excellent, important presentation. Actually, in the preliminary evaluation, I noticed that you put lower genital tract infection. What do you mean by lower genital tract infection? Vaginitis or up?
I mean endocervical infection.
Cervical infection, yes, but I think vaginitis
Yeah.
is not so important. Does it affect the results?
I think any genital tract infection is relevant to a pregnancy, potentially, preterm labor, potentially, microbiome and so on.
Any more questions? Thank you very much, Professor Kennedy.
Thank you.
And now is the time for Professor Tommaso Capizoli from Italy. He is a consultant in obstetric and gynecology at University Hospital Carigi, Florence, Italy. He will address us on ovarian endometriosis, infertility, and ART.
Good afternoon to everybody. I would like to thank very much Professor Serur for the invitation at this wonderful congress in this wonderful city. And I would like to thank my head, Professor Petraglia, to give me the possibility to be here with you. What is my topic this afternoon? My topic is a hot topic, that is the relation between ovarian endometriosis and infertility, and the treatment of infertility caused by endometriosis. It's very, very difficult to speak about this topic after several excellent presentations by very, very good colleagues. But I will try to do my best. I am more a specialist in endometriosis than in assisted reproductive technology. So, as we know, endometriosis is a chronic inflammatory disease that interests a lot of women all around the world. And it's interest up to 50% of infertile women. If in case of mild endometriosis, the monthly conception rate is between 2 and 4.5%. In case of severe endometriosis, the conception rate is less than 2% per month. Compared to the 15 to 20% of normal couples. Which are the mechanisms interested in the pathogenesis of endometriosis-associated infertility? Endometriosis is not a unique disease. We have ovarian endometriosis, the OMA, the superficial endometriosis, and the deep infiltrating endometriosis. Considering that we have common mechanisms of infertility that are common for all phenotypes of endometriosis, specific mechanism for SUP and DE, and specific mechanisms for OMA. Considering the common infertility mechanisms, one of the principal is the implantation failure. In fact, in endometriosis women, we have an increased proliferation and cell survival with a reduced antiproliferative progestin activity that drive to an increase of inflammation, to inadequate stroma differentiation, and to endometrium remodeling, with an endometrial defect and non-receptive endometrium. One of the protein that seems to be involved in this complex process is the glycodelin A. that it is strongly elevated during the late secretory phase of endometriosis patients. Also, this protein drives to a receptive endometrial environment with inflammation, apoptosis activation, and immune deregulation. Considering in a specific manner SUP and D and infertility, these phenotypes drive to interfere with the release at tubal pickup of the oocytes. They can cause tubal narrowing and constriction and obstruction, with fimbrial distortion and in some cases also occlusion. In some cases, hydrosalpinx with severe damage of the salpinx. And finally, above all, in case of DA, the presence of strong inflammation and adhesions in the pelvic cavity causing a distortion of the architecture. What about OMA? Considering OMA, we have two different kind of process implicated in the OMA associated infertility. In particular, the first is the inflammatory reaction with an increased number of immune cells, elevated level of cytokinase, chemokinase, and reactive oxygen species, and tissue fibrosis. But we have also the mechanical damage. In particular, we have to consider the compression and stretching of ovarian tissue, the damage caused by previous surgery, the presence of adhesions, the alteration in the ovarian blood circulation, and the presence of disturbed neovascularization. Also, the oocyte quality is altered in patients with endometriosis. In particular, granulosa cells, the follicular environment are interested, but also we can have some morphological changes in oocyte, and all this process drive to lower oocyte quality and a lower embryo number. Finally, all the inflammatory microenvironment of the pelvic cavity is interested in endometriosis-associated infertility, with some alteration in peritoneal fluid, with the reduced sperma motility and binding, reduced tubal motility, and adhesion creation. What about the management of infertility in ovarian endometriosis? We can manage with assisted reproductive technology, or we can manage with surgery. As we know, previous surgery for endometriosis is a very, very strong risk factor, both for infertility and for poor response to hyperstimulation. These women have difficult to become pregnancy, and they have a poor response to the stimulation. In case we want to do a surgery, and is very, very good to use the endometriosis fertility index from Adamson, that is a scoring system that predicts the chance of pregnancy after surgery. The score is for the most important part of the score are the tubal and ovarian function, but it is based only about historical factor and surgical factors. A low score has a low chance of post-operative pregnancy, and a high score, a high chance of post-operative pregnancy. In case we decide to do an endometriosis surgery for OMA, considering the last Escher guidelines, we have to give a specific caution in order to minimize the ovarian damage. And in this case, for reduction of recurrence, cystectomy is better than other techniques like drainage and coagulation. But surgery for endometrioma is can be dangerous, and we have to pay attention, particularly in case of bilateral and multiple surgery. Another technique that was recently introduced is the laser technique that seems to drive low heat damage compared to bipolar energy. But we have no robust data about this, and still nowadays the traditional cystectomy remain the main treatment. What are the risks of surgical choice for an endometrioma? In case of surgical choice, we can have a lower EFSS, lower number of developing follicles, and higher risk of no response to the ovarian stimulation. So, it's very, very good. It's better avoiding surgery in case of asymptomatic isolated oma. In this case, in case of isolated oma, we have to operate, we have to think about if operate only in case of pain or in case of doubt of malignancy. What about the art choice? We know that women with endometriosis undergoing IVF or ICSI had similar reproductive outcomes compared with those without the disease. And a previous surgical treatment did not improve the chance of IVF or pregnancy after IVF. So, considering GART, GnRH antagonist or progestin seems to be the proper first choice for ovarian stimulation. Low quality evidence support frozen toward overfresh embryo transfer, and ovarian stimulation for ART does not seem to be associated with symptom progression or recurrence. UE may be considered in case of minimal to mild endometriosis with anatomical distortion. What are the risks of ART in case of OMA? The risks are very, very low. There are difficult oocyte retrieval for pelvic adhesions, the punction of endometriosis with risk of infection, and the increased recurrence of endometriosis, but it is doubtful this. What about the endometriosis on the endometrioma sides in case of ART? In this recent study of the group of Professor Chaperon, the factors that significantly reduced the number of oocyte retrieved seems to be women's age, smoking habit, day 3 FSH concentration, and a previous history for surgery for ovarian endometriosis. But the authors detected no significant difference in the number of oocytes retrieved according to endometrioma sites. If you do a retrieval in case of endometrioma of 4 cm or 8 cm, according to the authors, the results is very, very similar. The same group and other groups all around the world studied how to improve the ART outcome of in case of endometriosis. An option can be the deferred embryo transfer. In order to reduce the estrogenic microenvironment of endometriosis and to improve the endometrial receptivity. In particular, it seems to be associated with significantly higher cumulative ongoing pregnancy rate, and this is an attractive option that could increase their ERT success rate. But OMA is an isolated diagnosis? Absolutely no, because several studies have shown a strong coexistence of ovarian endometriosis, superficial endometriosis, and deep infiltrating endometriosis. So it's very, very difficult that you find an endometrioma alone and to treat only the endometrioma. You have to consider all the associated phenotypes. In particular, OMA is associated to SUP in 20% of cases, to DIE in 18% of cases, and to both in 15% of cases. But in my opinion, these numbers are underestimated. What about the coexistence of OMA and deep infiltrating endometriosis? In the last year, several studies has detected an increased pregnancy rate after surgery for deep infiltrating endometriosis. Recently, this meta-analysis detected a statistically significant benefit performing surgery for deep endometriosis before IVF, even if they should be confirmed with randomized clinical trials. As discussed yesterday, the lack of randomized clinical trials on this topic is very, very important. Obviously, surgery should be performed by an experienced surgical teams with aim of reducing the risk of complications. Also in this case, surgery if we decide to do surgery, we have to consider the symptomatology of the patients. Surgery for deep infiltrating endometriosis is indicated in particular in infertile patients with symptomatic pain. Obviously, in case of endometriosis, we have to avoid repetitive surgery. And in this case, we detected in this study of our group, we detected that hormonal treatment before and after the first endometriosis surgery reduced the risk of recurrences and reoperations. If you want to operate a patient not considering the infertility, it's very, very important to prescribe an hormonal treatment not only after the endometriosis surgery, but also before, considering these results. So, what we have to do in case of OMA and DIE, surgery of heart? There is not any conclusive answer. We have to evaluate the single patient, the single situation, the single symptomatology. We have to consider painful symptoms, age and preferences of the woman, considering also the lack of randomized clinical trial. The choice of patient is very, very important. Ovarian reserve, estimated AFI, and other infertility factors, and history of previous surgery for endometriosis. Obviously, a patient's in a case of patients already operated for endometriosis, ART is the third choice treatment. But endometriosis is only associated with, ovarian endometriosis is only associated with superficial endometriosis and deep infiltrating endometriosis? Absolutely no, because endometriosis is frequently associated with other uterine disorders like adenomyosis and uterine fibroids, with a high rate of coexistence of the pathologies. In particular, considering adenomyosis, there were published several studies on this topic, one of our group, and we detected a coexistence of endometriosis and adenomyosis in 21 to 47%, and a coexistence of endometriosis and uterine fibroids in 20 to 30%. But endometriosis is also associated with uterine disorder? No. Endometriosis is frequently associated also with systemic comorbidity, because women with endometriosis has a higher risk of autoimmune, endocrine, mental health conditions that may contribute to give a worse quality of life and to reduce the chance of pregnancy of women of endometriosis. For example, the presence of autoantibodies associated with thyroid dysfunction or the systemic lupus erythematosus can have an important function in reducing the chance of pregnancy of these patients. For concluding, the first treatment choice in case of asymptomatic infertile OMA is ART. Asymptomatic infertile OMA with no doubt of malignancy. OMA is not an isolated disease. It is important to evaluate and treat concomitant DA or associate uterine or systemic disorders. In case of concomitant symptomatic OMA and DA, surgical excision or surgery followed by ART may be an option, but all these factors should be considered. In case of asymptomatic patients, surgery could be considered as second-line treatment after ART. And very, very important, avoid multiple surgery and refer patients to specialized centers with a multidisciplinary approach. Thank you very much.
Any question for Dr. Kabzuri? Okay, please.
Thank you, Professor Tommaso, for your nice presentation. When you have a small endometrioma and you're doing ovum pickup and you accidentally aspirate the chocolate material, do you advise to have a fresh transfer or you postpone your transfer as a freezed embryos?
We postpone the transfer and we do the antibiotic therapy.
Just antibiotics?
Yes, we prefer.
My second question, do you think that pregnancy with small endometrioma will go
Sorry?
Do you think that pregnancy
Yes.
with a small endometrioma, say 3 centimeter, would going to affect this size later? Because the ISHRI guidelines in 22 said nothing will happen. And sometimes we didn't find it when the patient got pregnant.
I agree with the ISHRI guidelines. We have to check the endometriosis sites and aspect during the pregnancy, because we all will know that endometriosis may modify its aspects during the pregnancy and may seem malignant conditions in some situation. We have to check, but We have to inform the patient. I am speaking about the decidualized endometrioma. We have to inform the patients and the colleagues that it is not, we have not don't to be worried about this situation. We have only to check. And after the pregnancy, the decidualized endometrioma will return to the original aspect.
No more
Thank you
question?
for a very good presentation. What about the best protocol في حالات in cases of endometriosis? Agonist protocol or antagonist? If the best is the agonist, the mid-luteal agonist or short agonist or ultra short agonist?
We prefer antagonist protocol. Also in case of, above all in case of deferred embryo transfer. Antagonist.
Okay, thank you.
Thank you.
Well, that brings us to our final speaker of this session, and it gives me great pleasure to introduce Professor Eric Genot, Professor of Obstetrics and Fetal Medicine at the Institute for Women's Health, University College, London. And he's going to speak on tubal ectopics versus caesarean scar pregnancies, similitudes and differences. Sorry.
He's over there. Right. Wolfgang, we haven't forgotten you. Right. Professor Gamal, as they call you, thank you very much again for inviting me to this brilliant conference. I've been coming here since, I think, number 2 conference. So I'm not only very familiar with the conference, but also with the setting, which is amazing. And I would like to personally thank Madame Azza, because without her, we wouldn't be here either. She is doing a fantastic job to, support us in every aspect of our travel. So anyway, so I've promised Gamal, Professor Gamal, never to present twice the same lecture. And so I've kept my promises so far, which is not always easy, because when you focus on a specific topic, you end up having to overlap a lot of the time, but this is a brand new lecture. Well, let's start with a bit of a history, because that's what brought me to Egypt in the first conference, talking about the history of ancient Egypt, but this is the history of medicine, and the first successful treatment of a tubal ectopic pregnancy, which has been known to medicine for centuries, comes from Birmingham by Robert Lawson. Of course, there were no medical publication at the time. I think the Lancet had just started, but he published this in his book, so it probably went a little bit astray, but it's being rediscovered by a historian of medicine. But the first case report of a tubal pregnancy that was treated is that of Sir William Japp Sinclair in 1902. It's one of the first issue of the journal. And then you see the gap between this type of ectopic pregnancy, the tubal ectopic pregnancy that we know very well, and the scar pregnancy, the scar ectopic pregnancy, as we should call it now. That only became aware, of this complication in the 1990s. And the main reason is that in 1884, there were very few cesarean sections being performed, same in 1902. And of course, this is a new condition that we have created. Well, the epidemiology is also well known. An ectopic pregnancy is the implantation of a 7 to 8 day post-fertilization blastocyst outside the uterine endometrium. Ectopic pregnancies are about 2% of spontaneous pregnancies and represent about 5% of ART pregnancy. So this is something that you will find more commonly in your world, especially in IVF treatment. 90% are in the ampullary region of the fallopian tube, and they're called regularly now tubal ectopic pregnancies. 10% are in the cervix, the ovary, the myometrium, the abdominal cavity, and then we have the scar ectopic pregnancy. These are the recent UK statistics, and it shows you that it affects about 1 in 2,000 pregnancies. I suspect that in Egypt now, and I saw on BBC News a confirmation that you have reached 72% of cesarean section nationally. If you compare this to the 29% in the UK, your incidence is probably much higher. I would reckon that in the next few years, you probably will have 1 in 400, even more commonly than that, cesarean ectopic pregnancies. Right, what's the pathophysiology? Tubal pregnancies are mainly due to the damage to the fallopian tube, usually secondary to an inflammation, which induces a tubal dysfunction and can result in retention of the oocyte or embryo. So you can understand why it's more common in your IVF population. The uterine scar pregnancy is a completely different pathophysiology. If you cut a muscle, it never repairs. What you get instead is collagen, myofibers, these array tissue edema. You get a scar with a lot of inflammation and elastosis. Your lower segment in particular is extremely fragile. Of course, we're not going to go back to classical C-section and cut, the upper segment of the uterus, because that would be a disaster for the next pregnancy. But we have to keep in mind that the more cesarean section we're doing on the lower segment, the more scar tissue you get. And after 3 or 4 cesarean section, it's only a scar, basically, that you're dealing with. You have less muscular fibers, so this contracts much more difficulty. And if you reach the cervix, you only have 10% of muscular fibers. So your tissue is becoming thinner, increasingly thinner with the number of cesarean section, less elastic, much more prone to injury than the intact muscle. And we've known for many years that between 1 and 10%, depending on the circumstances and the use of oxytocin, will risk having a rupture during an attempt at vaginal birth after cesarean section. Now, with improving ultrasound investigation of these patients, we now have better definition, because for a while it was a bit nebulous. How did you define a cesarean scar? Now we have the cesarean scar defect, or isthmocele, or niche, which is the loss of the uterine wall, leaving a residual myometrial thickness. I'm not sure there are many myofibers there. It's mainly fibrotic tissue, which is less than 1 or 2 millimeters, depending on the definition. And again, you will find the incidence of this early scar defect in about 40 to 70% of studies, and in increase, of course, with the number of cesarean section. It's much more common in patients who have erythropleutic uterus, because as soon as the uterus starts, going back to its original position, it puts tension on the stitches that you've put in. Remember that you're putting the stitch at the cesarean section not to repair the muscle, but to stop the bleeding from the edge. So your muscle is damaged forever. So of course, if you have any tension when that uterus is going back, you open the scar, and a patient with a retroverted uterus that had 3 or 4 cesarean section is almost certainly going to end up having a serious scar defect. The location of the scar, the lower you go, the less muscular fibers, the more, the size of that scar defect. And then there's a lot of debate, but very poor epidemiological data on the type of surgery and surgical technique that we use, single layers, double layers, lock layers. I'm not going to have time to discuss these. Now, interestingly, if you look at tubal ectopic pregnancy, there's very few pathology data, but they have shown that, of course, the extravillous trophoblasts, which are these cells that, favor the placentation and development of the circulation inside uterus, of course, they also exist when you have a tubal ectopic pregnancy. They will manage to invade the tubal vessels, which means they are going through the serosa, which is quite interesting. Of course, after a certain number of weeks and the size, if it's an evolving placental tissue, you will end up with rupture, and all the little vessels that have been recruited by the placenta will explode. Now, scar pregnancies is completely different. The only study that we have is this one from my colleague David Jurkovic, and it's basically a study that has shown that in case of large niches, your endometrium fails to recolonize the area. So it becomes a gap just made of this scar tissue with very little endometrium. When you look at them on scan, it's really an empty space. Now, of course, in normal placentation, as I said, you have these extravillous trophoblasts that migrate. I don't like the word invasion because it's confusing a lot of people when you talk about placenta accreta and people obsess about placental invasion. Of course, the placental villi don't invade unless they are carcinoma. You know, your healthy placental tissue does not invade anything. It just happens to be there. But what invades, what really migrates, are the trophoblastic cells that come from these anchoring villi, go deep, normally in the myometrium, superficially to the layer, in a zone that we call the junctional zone. And that's what helps the transformation of the vasculature and enables a normal placentation. Now, of course, if you have destroyed that area completely, there is no junctional zone anymore. You have no spiral arteries to transform. So these extravillous trophoblastic cells, they're going to migrate into your radial artery or even into your arcuate arteries. And these are big vessels. So if they are being transformed the way the spiral arteries are being transformed, you can imagine the flow that's going through those later in pregnancy. It's enormous. Interestingly, we were discussing this recently, these cells don't seem to be able to cross the serosa. And in most design section, we don't close the serosa. It just regenerates itself and starts covering the scar. So you find your extravillous trophoblasts up to the serosa, and then it stops there. So there must be something in the serosa that stops them from migrating, like there is an intact uterus at the level of the junction zone. Because in a normal intrauterine pregnancy with no damage to the uterus, they stop there. So it's a very interesting area of research, and there is very little research going on to understanding the physiology of the uterus. I think it deserves much more. We have concentrated our attention as maternal fetal medicine specialists to the fetus, to maternal disease, and we've forgotten completely the uterus in between. So, of course, there might be someone one day who will invent stem cells that can regenerate the muscle that's been damaged by cesarean section. It's a bit of science fiction at the moment. There has been experiment on rodents in China. So it inevitably will come from China, I'm sure. So to better understand the pathophysiology of scar ectopic pregnancies, we decide to look retrospectively, because we don't get many patients who decide to continue with these pregnancies, at a group of patients who were diagnosed with a scar pregnancy and decide to get on with the pregnancy. So we can only identify 27 in our database, and the database has about 300 cases. We are one of the national referral center for that pathology, and my colleague, Professor Jurkovic, has done more than 300 cases, managed more than 300 cases so far, and we get 1 or 2 cases every week, so the numbers are growing up rapidly. But anyway, so we compare that to a control group of intrauterine pregnancy, in the sense that they were not in the scar defect, they were just above the scar defect, so they were not, the gestational sac was not reaching the scar defect. These were all patients who had previous cesarean section, so in both groups, there was damage to the lower segment. And what you find immediately in those cases is an increased vascularity. If they are implanted inside the scar defect, you understand now why it happens, because you have the trophoblastic cells that have been transforming, and they invade very quickly. they migrate to reach this vessel within, a few weeks. And so this, when you put the color Doppler on, it's like a Christmas tree. You can see, the color coming up. If you compare to the controls, who is implanted just above the scar defect, you can see this with the arrow there, you don't get a sort of, excessive vascularization around. Now, an important point, because as I said, we're all going to be managing more and more of these patients, is the fact that if you compare the outcome, the natural outcome of tubal ectopic pregnancy with scar ectopic pregnancies, 92% of your tubal ectopic pregnancy are going to present as an early pregnancy failure with no heartbeat or no embryo visible inside the gestational sac. Now, it's quite interesting as well to realize that 66% of your scar ectopic pregnancy also present with an early pregnancy failure. But if you can provide your patient with conservative management for your tubal ectopic pregnancy, you cannot do this for your scar pregnancies because the placenta will continue to grow for a while, even if there's no fetal heart rate. And the consequence of this in an area which is just covered by a little scar and surrounded by big vessel, not tubal vessel, arcuate arteries, of course, can be dramatic. And we had a few patients who ruptured in that series and who nearly died. So why is it so different? It's probably because in your tube, you don't have the same access to nutrients that you would if you're close to the uterine cavity. Even if you're in that niche, you still benefit from the secretion coming from the transform and the metrium into the decidua. And these secretions are what nourishes, the early fetus in the first trimester. And you don't get, of course, this in the tube, which is the reason why in the vast majority of the tubal ectopic pregnancy, not only there is no heartbeat, but you have a much smaller gestational sac. It doesn't grow very well. Just to illustrate here, the gestational sac diameter, there is really a difference between these two groups. Well, so what happens, and why do you get, such a high rate of early pregnancy failure when they implant the scar? As I said, because you're close to these very, very large vessels, and so you have a premature entry of a large amount of blood into that early placenta, which you wouldn't have if it was in a normal intrauterine pregnancy, because it's a much more progressive phenomenon. And that can explain why a lot of these fetuses don't survive this excess of oxidative stress. But the placenta can, as I said, and so you have to offer these patients some form of management, because they're very likely to rupture. So overall, remember that both tubal ectopic and scar ectopic have a high rate of miscarriage before 10 weeks of gestation. So you don't have to rush to do things. If you identify a scar pregnancy at 6 weeks, you can wait another 2 weeks. Probably not too long after that, you need to have, either to do an ERPC, or if the patient decides to continue with the pregnancy, offer them some follow-up, but some advice as well about the risk. Because if you look at the outcome, which I didn't have time to present, of these 27 patients, most of them ended up in disaster, either because they rupture, like a tubal ectopic pregnancy, because a small shell that covers the scar pregnancy at some point rupture, or they ended up with a placenta accreta, a placenta previa accreta, which are the worst, or severe placenta previa covering the cervix, which also happens in our control group, but because it's not accreta in that case, it's much easier to deal with. So this is a group of patients that may be allowed to continue. It's their right to agree to want to continue their pregnancy, but we should be very careful in the way we advise them. For tubal pregnancy, similarly, you have time, but you're not putting the patient's life at risk. If you can see that the sac is decreasing, the HEG is decreasing, normally in those cases it will resolve spontaneously. In at least 50% of the cases that we see, we don't intervene. It's only in the live ectopic pregnancy that, of course, you have to do something quite quickly. But in the others, we let them and we follow them up until the sac has completely resolved. You cannot do that with scar ectopic pregnancies. As I said, because the risk of rupture with rapid intra-abdominal bleeding is quite high. And as I said, you have in case of the scar pregnancies a high risk of placenta previa accreta, about 50% of the case. And a few cases that have been published in literature, there's only one systematic review, so you have about 100 patients that have been followed up in what is available in the literature. There are no big database being set up worldwide to try to get better epidemiology data and get the patient better advice. No, there's a lot of things we don't know. And for example, there's probably a relationship between the amount of placental tissue that develops definitive placental tissue inside the scar. It makes sense. The more placental tissue, definitive placental tissue, the higher the risk of placenta accreta and rupture. And probably the remaining myometrial thickness is essential because the shorter the distance for these extravenous trophoblastic cells and the big vessels of the periphery of the uterus is of paramount importance in the prognosis and the risk of complication. Okay, so thank you very much for your attention.
Questions? Yes, please.
Thank you, Professor Eric, for your very nice presentation. Do you think in early detection of ectopic pregnancy and the management or treatment with methotrexate have the same effect regarding to these different kinds, the tubal and the scar ectopic, if you give the methotrexate?
I would be very careful with methotrexate in scar ectopic pregnancies because you're so close, to the big vessels of the uterine circulation that if there is a high risk, you will inject your methotrexate inside these vessels straight into the maternal circulation.
Do you mean systemic?
Systemic? No, it's not local.
Systemic. We have stopped doing this a long time ago because of the side effect. And it's the same in placenta accreta. There's been maternal death reported. So methotrexate, no, is a no-go zone for us.
Okay, there was that gentleman over there, yeah. Okay, we'll take you.
Thank you, Eric, actually, for your presentation. My question actually is, would you commend that actually CS scar defects are a wide spectrum of things in a three-dimensional actually configuration? And if you take the whole spectrum as one thing and say that wait for 9 or 10 weeks because 50% is going to abort, can actually carry a higher risk of very morbid complications. So the idea is actually on sonographic basis, we need particularly the three-dimensional aspects, the depth, the width of the niche as well, and as you mentioned, actually the overlying scar, and to which actually part of the lower uterine cavity or the cervix, it is bulging into. Because actually the bulges into the lateral aspects of the uterus is even the worst of them.
Yes. I mean, we need prospective studies, which is why this international database is very important, where you identify the patient before they become pregnant. Because obviously it's easier to evaluate the three-dimensional structure of the niche. Once they are pregnant and pregnancy inside the niche, it's very difficult to have an ID. So we really need to follow up a large group of patients after their first cesarean section, because in the UK they're not going to have 5 like in Egypt. But obviously you are in an ideal situation to do this kind of study because you have a lot of patients having cesarean section who are going to have repeat cesarean section and repeat pregnancy, of course. So this is what you need to do. We really need to start looking after these patients, not in Italy because that's 1.2 babies fertility rate. So even if you're working hard to try to improve them, in Europe it's going to take a long time to do this. But it's a very important point. I agree with you.
Okay, thank you.
Thank you so very much. Very, very interesting presentation. Well, in your opinion, do you think we caused what's called cesarean section niche or ethmosil by changing from the old good catgut and chromic catgut that obviously was banned because of the CHD to a polyglycolic acid? And if so, do you think it is worth thinking about returning back again to these sutures? I mean, the disease was non-existent virtually before that.
I know, and I think again, this is something we need to do prospectively and randomly. We need randomized controlled trial. I mean, often, doing things without any supporting evidence, so yes. But it is, I mean, it's like the locking of your stitch. Obviously, you interrupt the circulation, so you're theoretically going to increase more necrosis of the area, but this is just theory. So until we do really proper randomized controlled trial, it's going to be very difficult to prove that. I calculated one day that you have about 1,000 ways of doing a cesarean section.
1,000?
1,000.
Okay.
It's exponential.
I thought there was only one way.
I wish.
Yeah. Last question.
Thank you for your excellent lecture. I want to come back to methotrexate. Can't you give it in an early phase of this ectopic pregnancy or cervical pregnancy and dependent on the HCG level?
I mean, yes, we actually in my department, we did a randomized controlled trial, and we found that it was a nightmare to follow up these patients. So we abandoned the technique. So I don't have any further comment because it's not something we do routinely.
Okay, no more questions. Eric Genot, thank you very much for your interesting talk. Thank you. Okay, so our last speaker of this session is Wolfgang Holgrieve, who is Professor of Obstetrics and Gynecology in the University of Munster. And he also has a position in genetics at the University of California in Berkeley. In 2020, he was re-elected as medical director and CEO of the University Medical Center Bonn for a period slightly longer than, I think, Xi Jinping in China, certainly through to 2026. Thank you. You're going to talk on an update in non-invasive prenatal diagnosis.
Yeah, distinguished chairs and audience. Even though I have to rush now, I would still take the chance to thank Gamal Serur for inviting us, because it's not only the exposure to this fantastic meeting, but also to the Egyptian culture, as we see in the middle slide. And I told Eric when we were both at the pool over lunch that I remember I was here when the change of the millennium took place. And then an Egyptian friend said to me, yeah, I understand all this excitement in Europe. We had it 3 times before. So this shows you here a picture of Bonn, where I work, and there is a collective mourning today because Germany dropped out of the World Soccer Championship last night. The update I wanted to give on non-invasive prenatal diagnosis is straightforward, because it's now a routine to look for trisomies early, non-invasively. And this, for example, is one study by one of the companies who I counsel occasionally, Natera, and they just published a very large study. You see here more than 20,000 cases, and if you look at the performance, it's very similar to the other companies, and it's interesting that this field, even though it was pushed, of course, in academia, all the basic research that I will speak about, but now it went over to companies because you need many, many sequencers in routine, and usually academic medical centers don't have those. But it is maybe a good example of how it should be, that you kind of hand over something that is developed. In some countries, it's done in the public domain. It differs. The results are pretty much all the same, and they are amazing. If you look here at this study that I just mentioned, sensitivities and specificities are now in this range of 94% for trisomy 18 to 99 point something for trisomy 21. So this is a big advantage, I would say. And what I want to talk about today is not only those results and the outlook, but also what we learned along the way, because there are these, I think, very important lessons. It went on from the chromosomes, of course, to the structural anomalies and the single gene problems. And you see here, of course, the specificities still are very high for those. Therefore, in those circumstances where there's a specific risk for any of these anomalies like DGeorge, Prader-Willi, and so on, you can offer it. The sensitivities are a little bit lower, and therefore maybe the most important message in this whole area is that always there has to be good counseling beforehand so that there are no wrong expectations, but we can offer a lot. And this has led to the fact that already since 2015 or so, most societies of genetics and obstetrics in most countries have recommended that this now should be offered to all women in all age groups, even though the counseling has to be specific, but there is an offer for every woman, and we see that in most countries that women make their choice disregarding of their age, whether they want to use this non-invasive method. It's interesting that the research now has great impact on many other fields. In Bonn, we are particularly, or have been particularly involved in the area of developing in oncology these checkpoint inhibitors, and actually there were two really major companies that originated out of that. Now, last week actually, by the same Natera company, there has been a very, I think, nice paper showing Nature that you can use this technology now to monitor the effect of this treatment. The treatment has side effects. It should not necessarily be offered to everybody. And now you can measure the degree of apoptosis, whether you achieve what you want to achieve by looking at the free DNA of the tumors. And in a way, it's somewhat similar to the situation with the mRNA vaccines that have been used with good success for COVID. The same technology can now be applied in other circumstances. But coming back to the non-invasive prenatal diagnosis, in a way, NIPT is like an end point of these efforts to develop screening technologies. It started in the 70s, alpha-fetoprotein being a marker for neurotube defects. It was then found that low AFP can be predictive for Down syndrome. Then HCG, free beta got involved, PEP-A, and so on. The triple marker screening, nuclear translucency, we got better and better, but the false positive rate was still high, and that is now extremely low, way below 1% with NIPT. So it's still a screening test, but it's the best screening test we have. And now quickly to those lessons that came along with the research. The research for us started almost 30 years ago. That's when the probes became available to, for example, identify the Y chromosome. If the woman was carrying a boy, we wanted to find out how frequent are these cells. Answer 1 in a million. And the motivation, even though after that there were, I would say, 15 years of frustration, it didn't work, was that all of us doing invasive procedures know the risk. Even though when CVS was introduced, then the proper thing was done. In the beginning, a randomized trial comparing it with amniocentesis. The result was interesting. In 3 studies, the Canadian, 2 Scandinavian ones, the risk was the same. The procedure-related risk. There was a big multi-center MRC trial. CVS was much more risky. What is the difference? They were all randomized studies. The difference was that in those first 3 studies, it was experienced people who knew what they were doing from many, many procedures they had done before. In the multi-center trial, there were some centers, you couldn't maybe even call them centers, who had less experience. What it shows, and I tell that to the medical student, a randomized study is the way to really find out what's going on, but you have to know the entry criteria. Otherwise, you might still be misled. But it was a good example of how to introduce it. And with amniocentesis, it's interesting. A lot of us now say the risk is so low in our hands because we are so good. The only good, really good randomized study was by Ann Tabor many years ago in Copenhagen, and she had a 1% risk. Maybe it's lower now, but we don't know because nobody can repeat a randomized trial again on amniocentesis or not amniocentesis. But the impact of all these screening tests is enormous. It already was obvious in the first 10 years or so after the screening started in Germany. These are data from the insurance companies. Amniocentesis rate went down to 1/10 of what it was before. CVS was half of what it was before, and now we even have the problem that we can almost not train our people anymore because there are so few of these invasive procedures. Then it was interesting that the first attempts to go for non-invasive prenatal diagnosis were looking for cells. You know, yes, it was possible because, of course, there are cells, especially nucleated erythrocytes, going across the placenta early. So if you enrich for those, using any type of enrichment technique, this was magnetic activated cell sorting, then you could identify cells. This is showing X and Y chromosome. The green is fetal hemoglobin. The first trisomy ever that was reported in Lancet was by Jolie Simpson, who might still be in the room here. I've seen him before. So that was exciting. But can it be offered to the public? That's another important lesson. At what level do you feel courageous enough to offer it? And then I think something happened that should be highly considered to be the way to go. NIH stepped in and did a randomized trial, 3,000 cases. These were women who wanted the new procedure, and they had follow-up amniocentesis. And then, this could be evaluated properly. The result was, here the last sentence, the recovery of these cells is difficult, not clinically practical. So the public was prevented from an immature, good technique, but not good enough for clinical practice. And this happens too rarely. In perinatal medicine, there are all these examples where things get into practice and only later it is found that they are not as good as it was assumed. Then, of course, the breakthrough very quickly, Dennis Lowe, at that time in Oxford, now back in Hong Kong. How did he get the idea of using cell-free DNA? Well, he read papers, always good to read papers in other fields, from cancer geneticists, Anker and Stroon, in Geneva at that time, and they had found cell-free DNA in plants, in the fluid of plants. And he then thought, why shouldn't it be the case in pregnancy that there's a cell-free DNA? Again, the proper studies were done immediately. 2 big studies, one by his group, another one by a company, Sequenom, and similar results. So then we could be pretty sure that this is a valid technique now. We did a big study on that in Germany, and all of that led to the fact that, for example, the insurance companies in Germany, everybody has an insurance in Germany, has picked that up. And here you see a certain meta-analyses that were done now. Last year, we compiled those, and you see sensitivities and specificities are amazingly high now for this technique. And as I said, in almost every country, the recommendations have been that it should be offered. However, it's still our counseling that we say if there is a positive finding, that there should be a confirmatory invasive study. Ultimately, I think I don't know, maybe that could even be dropped, but maybe it's too early to say that. What we see, however, already is that younger women are also taking care of this technology, not in the past where age was such an important factor. However, the counseling has to be differentiated. So for a woman younger than 35 compared to a woman who is older, the sensitivities and specificities are different. Of course, depending on the prevalence, there are still different techniques that you can use. I think the SNP technology turns out to be one of the better ones. Also, looking at the fetal fraction first, which on average is 10 to 12%. But we now have interesting findings how the fetal fraction is influenced, for example, by maternal weight. There are certain trisomies that change the fetal fraction, preeclampsia, and so on. So, like with the marker screening, in those markers there are additional informations that we can use for screening in pregnancy general, also for the prediction of some pregnancy complications. So what are these companies who offer NIPT? In Germany it's mainly offered by companies doing, and I think it is a good development. They tell what they can offer, but they always, and we pressed for that, the national societies, they also have to make sure that this is embedded in the proper counseling also if there is a finding. But they point out, we point out in our pregnancy care, what the likelihoods are to have certain problems in pregnancy. So for like 10,000 births, the likelihood of having a embryo with trisomy 21 is 14. If you add up the non-trisomic findings that are of importance, that is even higher. And we always, and I see that critical in our research, but also in our patient care, have paid so much emphasis on the aneuploidies, you know, all these big work around nuclear translucency and so on. It is important, but if you look at the 2 to 4% of children who have anomalies at the time of birth, congenital anomalies, aneuploidy is only a quarter. And if you look at the structural anomalies, especially of course heart and others, it's much higher, and many of those now have genetic markers that you can look for. The whole development of this technique, I think, was fascinating, because also the example of rhesus, which already was years ago in the year 2000, that specificity and sensitivity was very high for the rhesus factor. This has now led to many countries who routinely offer this test to rhesus negative women. And then, of course, you only have to be concerned about those pregnancies where a boy is carried. The second most frequent blood group incompatibility, CAL, can be diagnosed non-invasively now. Of course, you can identify in X-linked diseases first the gender of the baby, and then this was done for Duchenne muscular dystrophy. I think it's a great offer to all these families who have this high risk and are concerned that you can offer it non-invasively. What about the single gene anomalies? I've shown that they are in aggregate as frequent as aneuploidies. Well, if the father carries the mutation, it's straightforward. You look for the mutation non-invasively. If it's there, the child will be affected, and this is, of course, the case then for 50% of the offspring. This was our first case. It was an achondroplasia situation. The father had achondroplasia. They only wanted to know, was a couple from the Netherlands. They never considered termination, but they wanted to be prepared. This was still southern blotting. You see on the right, the very right panel is the embryo, and was affected, and the parents were better prepared to have another child with this problem, myotonic dystrophy and so on. What about autosomal recessive? There it should be difficult, because then, of course, if both parents have the same mutation, how should you be able to differentiate that from the homozygous state? But what helps us is, of course, the fact that there are so many mutations for the same disease, like, let's say, thalassemia or cystic fibrosis, that the more frequent situation is the compound heterozygotes, where the father and the mother have different mutations, but the disease is there if both mutations are inherited. So we applied that to thalassemia, and it works quite nicely now. It's of course a frequent disease in many countries around the Mediterranean Sea. And it kind of illustrates the whole history of prenatal medicine, because we first did fetoscopy, chordocentesis, and so on to look for that DNA from amniotic fluid. And now this is so much easier. And while doing it, it was interesting that in our group, Dr. Lee found that you can enrich for fetal DNA by size separation. Fetal DNA is in the smaller fractions. And there are other methods of enrichment, and there are major patent trials going on around these enrichment steps. This I think is sad, because all those people should unite on that. But here, this is a reference to a paper, a recent paper, where it is shown that if you use all these different techniques available now, in the majority of cases, you can diagnose single gene diseases, even those who are inherited in the autosomal recessive way. I want to finish by showing again the value in the structural anomalies. They are of course not affected by age. So you see for trisomy there is this strong age relationship. For the subchromosomal changes there is no age difference. And here you see that if we start with the other non-trisomic trisomy and add them up, you come up to 30% that can be diagnosed now. And this is also something that is not published yet, but the results are available. This is on D. George, so this is a change on the chromosome of the long arm of chromosome 21. And you see here that for D. George, sensitivity is also now between 70 and 80%, but specificity, and that's of course what they are mostly interested in, the couples at risk, is 99%. So this is now of course a big progress. There are 30 genes that have been already diagnosed non-invasively, and so the last question is, what about whole genome sequencing? Of course, it can be done as well. I'm a little bit critical about that, because the same will happen as if it's done on amniocentesis. You will find all these variants, and then the counseling can be a nightmare. Women will be frightened. If you do it properly, it can be done, and I find it excellent that the Netherlands are doing a study on that, so very soon we will have the results. Very last point, and that's why I think this field is so interesting, that of course we have spent so much time on diagnosing, and often in the end the question is termination or not, which is of course not satisfying. What about the prenatal therapy? And yes, there are these examples. Let's look at, for example, SMS, SMA, the spinal muscular atrophy, not too rare. There, it is very helpful to know it as early as possible, maybe by prenatal diagnosis, because there are excellent form of treatments now, and the earlier you start them in the child, they better work. Using antisense oligonucleotides, there are these very expensive but very effective forms of treatment. So we now have the situation that for many prenatal diagnosis, we still have a therapy to offer, but we have this other growing area where the early diagnosis helps us to start therapy earlier to the benefit of the affected child. So I close with this picture. This whole development of non-invasive prenatal diagnosis had a lot of frustrations. There were periods in between when we were asked, do you think it will ever work? Maybe not. You are spending money. It will never work. Now it works. So here on the face of Angela Merkel, who was chancellor in Germany, is for 16 years. You see, you can go through all these phases in this research. I think the left picture might be related to soccer yesterday. Thank you very much.
talk. Thank you. Any questions, please?
Thank you so much. Very interesting topic. But in practice, we have two problems with the cell-free DNA. Number one is the cost in this country. It's quite above the tolerability, I would say, of the common Egyptian, especially if we know that most of these are sent to Europe, to either in London or in Germany to be processed. The second is a burning question: what happens if it comes positive? And I turn to exactly what you said, we'll go for amniocentesis, and then the patient says, so what makes this difference? It has a very good specificity, so it's a good negative test, but still the problem is you cause the patient, and if it comes positive, you return it back to the amniocentesis. Do you have any clue to what should we do? Thank you so much.
Yeah, this first question about the costs, of course, is a very important one that has to be discussed in all societies. And it took a while also in Germany, a little bit faster in Switzerland, to come to a consensus on that. You have to, of course, to balance many types of costs against one another. If it saves so many invasive procedures that I've shown, and that is an ongoing trend, of course you can also put that into the calculation. You save money on the one hand and you spend something on the other hand. And then it becomes a question of the healthcare system. You know, if you have a healthcare system where the insurance companies in the end make a decision what costs should be kind of transferred to the solidarity of the whole community, then it can work out, but then the price will go down, and that's what happened in Germany. There was a lot of pressure on putting the price down, but at the same time it was offered and covered for everybody by the insurance company. So maybe that's a way to go. In a system where the insurance company or the general health coverage is not so prevalent, it's more difficult. But I think it's the same discussion in every country. The other question, if you still do an invasive procedure, that somebody might say, why don't you do it in the first place? Again, it's balancing the numbers of procedures you have one way or the other. And I personally think, you know, for all of us doing these procedures, we might think that I probably, and like Eric and many in the room have done, I don't know, 10,000s of procedures. We think they are very safe in our hands, but we all know the situation. There has been a loss, and then we never know whether we caused it. So I think there is should be a very strong motivation to reduce those.
Julie?
Thanks. Thanks, Wolfgang. A great talk as always. Thank you for the citation, but of course you and I realize that any discovery requires a team. You know, it's just not a single person that needs to be singled out. I'd like to ask you to move to a different direction, and I'm sure you do. Many people here are not doing amniocentesis or may not even be doing obstetrical follow-up, but huge numbers of people are doing IVF. And huge numbers of people are interested in pre-implantation genetic testing, and of course, non-invasive screening or testing, if you want to call it that, based upon spent culture media, is the technique that we're looking at there. And I wonder if you could just speculate that. Many of us, you know, the best of hands reported as much as an 80% detection rate. Which is not bad, but it's not 100%, as we know. But the issue that I have is, can you comment on the concerns that you might have, and some have, for the fact that some of the cells that are being expelled in the early embryo are not typical and are not the same as what the remaining embryo would do? So in other words, is the embryo smart enough to kick out the cells that don't belong there, and therefore we're testing not what we needed to be tested, which would be cells from the trophectoderm perhaps in the inner cell mass?
That's of course good for another evening discussion of many hours. But of course, you know, this link between reproductive medicine and prenatal medicine diagnosis is so clear now. And I mean, I mentioned Natera just as an example. They started out with pre-implantation genetics, as you know, and then expanded also in the field of prenatal diagnosis. But of course, the genetic techniques that Joe Lee and I and others perform can be applied to those different situations. Regarding this expelling of cells, I really think that we can be pretty sure now, as earlier you are, of course, the higher is the rate of mosaicism, and that we see so few cases of trisomy at birth just means that this, you know, selection process takes place. But then, of course, having this information on the mosaic cell lines that later is lost early now turns out, as you know best, to have predictive values also for other outcome parameters of pregnancy. So they help us with identifying the at-risk pregnancies. So I think there are still many questions, and also insights that I even didn't mention for time reason. This whole issue of chimerism, where, you know, a fetal cell later can cause problems in mothers that look like autoimmune disease, but they are alloimmune disease because they react to those stem cells that came across from the fetus and are still there. This has been shown for scleroderma, for thyroiditis types of diseases. So I think this field will keep us busy for many years to come.
Thank you. Okay. Thank you very much for the lecture. But maybe you would like to elaborate a little bit more on the interpretation of the non-invasive tests in multiple pregnancy. What's your protocol in these cases? How do you interpret it, the results of
Yes,
these
also
tests?
a very good question, and I think these different techniques that you can use nowadays regarding the multiples, you are best off using the SNPs for obvious reasons, because then you have information on every individual embryo fetus. And if you use these technologies, certainly this technique can now be offered also in twin pregnancies.
Sherman?
This is a simple question. For twins or even triplets, can you use that SNP technology to diagnose each one of them individually?
Yes.
Straightforward answer.
In the end, it's statistics, but they work out very well now. There are trials on that and publications, and if you use these safeguards, you can offer it in twins.
Okay, Wolfgang Holgri, thank you very much. Great talk, thank you. So I'd like to now join with my co-chairs in thanking all of our speakers for what I think has been a great session, and give my colleague from Egypt the honor of the closing remark.
Thank you very much. I would like to thank the speakers for sticking to the time, and thank the co-chairs, and of course thank the audience, and thank you.
We'll start the next session straight away now, the IPSA-sponsored symposium session. There's no coffee break yet. Coffee break is after half an hour. لا ما كانش Okay, if you'd like to take your seats, please. Okay, good afternoon, ladies and gentlemen. So we'll start our next session, the EFSS sponsored symposium. I'm sure you all know about EFSS. EFSS is one of the giant companies, especially in the market here in Egypt. They have many medications and they sponsor many events. And with us here in the Egyptian Fertility Sales Society, they are, well, a strategic partner. We always thank them for the support and their presence in all our activities. Now I have the pleasure to invite my dear friend, Professor Fouad Abu Hmeila, Professor of Obstetrics and Gynecology at Cairo University and at the IVF unit in Cairo University, to present us his lecture on progesterone, an update in the coming 30 minutes. Professor Fouad, please.
بسم الله الرحمن الرحيم. ممكن اللي هيتفضل يحضر يقعد عشان ابتدي. كل واحد براحته يعني. اولا بتشرف بوجودي معاكم النهارده في المؤتمر في this presentation. It's a simple presentation after the highly advanced topic in the NIP technique and the prenatal genetic testing and the prenatal screening. الموضوع هو البروجستيرون and update. It's a basic topic. We'll see what is some recent updates in the basic topic which we all use in our infertility practice. It's not a complicated lecture, it's a very simple, straightforward lecture, and I hope it will be of benefit for all of us. دي البوينتس اللي هنتكلم عليها: introduction, the controversies in the luteal support, is there any role of the serum progesterone, and my conclusions. We're all familiar with this slide presenting the physiology of the normal menstrual cycle composing of two components, the follicular phase under the effect of FSH with estradiol, followed by LH surge, ovulation, corpus luteum, and the endogenous production of estradiol and progesterone, preparing for the implantation and the future pregnancy. What is the real action of progesterone? Why do we need progesterone? For three main reasons. Endometrial secretory changes. It produces myometrial relaxation for nitric oxide production, and possibly a more systematic effect through the immunomodulatory effect by the balance between the T helper 1, T helper 2, and the pro-inflammatory and the anti-inflammatory cytokines, decreasing the possibility of fetal rejection. So collectively, this would lead to what we all hope for, is the implantation of the early embryo and to achieve a clinical pregnancy as a start. As we all know, there are different routes for progesterone: the oral, micronized progesterone, which is not actually applied nowadays because of the hepatic bypass metabolism; the more synthetic form of progesterone, the oral dydrogesterone; the vaginal progesterone, whether it is a suppository gel or tablets; and the parenteral form of progesterone, whether the intramuscular or the subcutaneous form. Why do we need actually progesterone? As we all know, for the luteal phase support in our infertility patients, it has a role in threatened miscarriage and recurrent miscarriage according to the new NICE guidelines, and also the micronized vaginal progesterone has a role in the prevention of the preterm birth. Let's focus on our topic today, luteal phase support. First, in the natural cycle, ovulatory natural cycle, do we need a progesterone support in the natural cycle? According to this practice committee from the ASRM, actually there is no strong evidence that we need a luteal phase supplementation in case of natural ovulatory cycles, unless you suspect there is a luteal phase defect, which is actually difficult to diagnose, whether clinically by a luteal phase less than 10 days or a low serum progesterone level, and here comes the debate, which level of serum progesterone do we take, and should we do repeated serum progesterone levels, which is practically difficult to apply. So cases of natural spontaneous ovulation, I doubt if there is actually a need for luteal phase support. But what about ovulatory cycles or induction ovulation cycles, particularly if we are applying an intervention like IUI, which still has a role in our infertility patients? This was a comprehensive systematic review and meta-analysis in 2015 by Catherine Green. It included about 11 trials, more than 2,600 patients. Here the patients were divided into 3 categories in this meta-analysis: patients induced with gonadotropins or a mixture of gonadotropins and clomiphene, or clomiphene alone. And they found that there was value of progesterone supplementation or luteal phase support in patients when using induction of ovulation with gonadotropins or a combination of gonadotropins and clomiphene, but not a real benefit in clomiphene in only induced cycles. And the hypothesis is possibly due to, in these 2 categories of patients, there is multiple follicles, higher level of estradiol, and this would lead to a lower level of LH supplementation or negative feedback on the LH, so leading to some sort of corpus luteum dysfunction and some sort of a luteal phase defect. So these patients would benefit from progesterone supplementation more than patients with clomiphene. What about IVF cycles? As we all know, IVF cycles we use we anticipate to perform down regulation using analogs. There is multiple follicular stimulation leading to a higher level of estrogen, supraphysiological level of estrogen, inhibiting a pulsatile LH, leading to a disruption of corpus luteum and leading to some luteal phase defect. It has been postulated from past years that luteal phase support is beneficial in IVF cycles. In the 80s, where they used progesterone and HCG, and in the 90s and up till now. So actually, and again in the Cochrane review, which I'll talk later in 2015, so luteal phase support in IVF cycles by progesterone is actually needed to improve the implantation rate and to improve the pregnancy rate. And all of us do this in our practice nowadays. What about the controversies in luteal support? There is a controversy. Which route do we prefer? What is the dose? Is there any role of serum progesterone? As we all know, there are different, as I told, there are different modalities: oral, vaginal, intramuscular, gel, suppositories, subcutaneous. So this is, up till now, there is a debate, which is better. This was a meta-analysis. It is about 2009. It's published by Zarutsky et al. It included 9 RCTs from 1992 to 2008. And here they included about 1,600 patients, and they show what is the effect between the vaginal progesterone versus intramuscular progesterone. They showed there was no statistical significance, but here they evaluated the clinical pregnancy rate, not the live birth rate or the ongoing pregnancy rate. So according to the data in 2009, no difference between intramuscular and vaginal progesterone, and I repeat, according to the clinical pregnancy rate. This Cochrane review was very famous in 2015 by a Dutch group and our colleague Mustafa Mitwalli. And here they evaluated luteal phase support for assisted reproduction in general, the different modalities for luteal phase support, including progesterone, HCG, progesterone and GnRH analogs, progesterone and estradiol supplementation, adding estrogen to progesterone, different forms of application of progesterone. It was about 92 RCTs, including 26,000 patients. And they concluded that luteal supplementation using HCG or progesterone may be associated with high rates of live birth rate or ongoing pregnancy rate than placebo or no treatment. And actually, all they do this. But they stated that, which is also logical, HCG was associated with a higher hyperstimulation rate than progesterone alone, and they didn't find much benefit for adding estradiol. Other forms of progesterone have been also promoted, like dydrogesterone in 2017 by the Lotus 1 trial. It showed non-inferiority regarding micronized vaginal progesterone, and the Lotus 2 trial against the gel, non-inferiority for the dydrogesterone against intravaginal progesterone gel. So actually, a lot of forms are available. However, in 2019, this was a comprehensive systematic review and meta-analysis. It was presented in Nottingham University. It included about 82 articles, more than 26 or 28,000 patients. They evaluated the progestogen supplementation for luteal support in fresh, not in frozen, in fresh IVF cycles, including when to start the luteal support from the day of the pickup, day 1, day 2, day 3, or the embryo transfer, which form of luteal support, which route of progesterone do we use, intramuscular, vaginal, oral, rectal, subcutaneous, and the supplement, when to stop the progesterone, and the addition of estradiol, was it beneficial or not? So actually it was a comprehensive, and a lot of data came from this meta-analysis. And the results were that vaginal, or actually vaginal was the main route of application in most of the patients, about 16,000 patients. This was followed by intramuscular, about 6,000 patients, followed by the oral, and the rectal was the least evaluated, and subcutaneous. They concluded that our results have clearly established that progestogen supplementation via the intramuscular route offers the most benefit to clinical pregnancy. And these results demonstrate that the optimal time and the optimum time to start the supplementation is the day after oocyte retrieval, and that the clinical pregnancy rate will not improve by continued supplementation for more than 3 or 4 weeks or by the addition of estrogen. This lack of improvement occurred whether the gestogen were administered by the vaginal or intramuscular route. So they concluded that intramuscular actually gave the best results. However, do we actually do this in our practice? This is a question. This was answered in this article published in the Frontiers of Endocrinology 2020. Actually, it is a questionnaire sent to multiple practitioners. Who responded for this questionnaire were 148 clinicians in 34 countries. And what was the response? What we actually do? 80% used vaginal progesterone, in spite of the results from the previous data. Followed by intramuscular, about 10%, 6 to 10%, followed by a combination of oral or vaginal intramuscular. Subcutaneous is a very good route, but actually it is not much available here in Egypt now. It's a bit expensive, but actually it's a very good route, the subcutaneous. So up till now, vaginal route is the main route of application. Intramuscular will give good results when it is used either alone or in combination. I'm talking here in fresh cycles. The other part of the topic is about serum progesterone. There's a trend in the past years towards freeze-all policy or frozen embryo transfer. What we all know from the past that serum levels after intramuscular progesterone are typically supraphysiologic. They are much higher systemic levels serum after intramuscular injections. And the vaginal route provide a higher endometrial level despite low serum level. And the serum progesterone in the IVF cycle is not correlated with the pregnancy. And this was postulated 20 years ago by Williams and Gibbons, 22 years ago. Does this change? Everything is changing and it goes on and off, and the trends are changing. In the past decade, there was a trend when this statement was stated, most of the cycles were actually fresh cycles, not much frozen embryo transfer cycles. Now it's going a trend towards the frozen embryo transfer cycles. And in the frozen embryo transfer cycles, most of the cycles, they are used HRT, artificially prepared cycles. And here, actually, there is no endogenous progesterone, and there is suppression of ovulation and no corpus luteum. So they started to think, is the effect of the serum progesterone when giving the outside from the medications have any value? This question was actually addressed in 2015, one of the early studies in Australia by John Jovich. It addressed, is the mid-luteal serum progesterone concentration affect the implantation rate for the cryopreserved embryos conducted under hormone replacement therapy? And this started the debate, or started the spark. It was like a spark that was followed by a lot of work by different authors. In 2017, Elena Labarta, they evaluated the serum progesterone level in oocyte donation cycles that were prepared, HRT cycles, and they supplemented the progesterone in the form of micronized vaginal progesterone, 400 milligrams twice daily. And they assessed the level of the serum progesterone on the day of the transfer. And they showed that patients with serum level less than 9.2 nanogram per ml on the day of the transfer had a lower ongoing pregnancy rate. They said ongoing pregnancy rate. Later, 2019, another article by Martinez et al. In frozen embryo transfer cycles, but artificially also prepared, HRT prepared cycles, but here they measured the serum progesterone level 1 day before the transfer, not on the same day, 1 day before the transfer. And they took a cutoff level that 10.6 nanogram per milli. If less than this would lead to a lower pregnancy rate and a lower live birth rate. In 2019, Labarta evaluated the level of serum progesterone level throughout the luteal phase. They measured the serum progesterone level on day 4, day 7, and day 11 after blastocyst transfer in HRT cycles. And they using micronized vaginal progesterone 400 milligram twice daily, and they detected that the absorption of the vaginal progesterone was variable among the patients and among the days, and the higher level of the serum progesterone was associated with a higher ongoing pregnancy rate. And more recently, 2021, evaluating the level of serum progesterone in the HRT cycles, in oocyte donation cycles, and in own oocytes, they took the level of 8.8 as a cutoff value. Lower than this, lower ongoing pregnancy rate. So what to do? This led to the concept, a new concept they call ILPS, individualized luteal phase support. When we detect a low serum level of progesterone, do we do anything? Every action has a reaction. This was article, it was presented in 2021 in Human Reproduction. It was a prospective cohort study. More than 500 frozen embryo transfer cycles. The serum progesterone level was measured a day prior to embryo transfer. If the level was 10.6, this was Nicholas Pelotzis and Alvarez, was 10.6 or more, they classified this group as frozen embryo transfer group 1, and they proceeded to the embryo transfer. If the level was less than 10.6, they postponed the transfer and they supplemented luteal progesterone in the form of subcutaneous progesterone. In Europe, they used the subcutaneous progesterone. And they supplemented the subcutaneous progesterone, and for 1 or 2 days, and when the level was more than 10.6, they did the transfer, and these patients were classified as frozen embryo transfer group 2. And here was the results: frozen embryo transfer group 1, the blue, and after the supplementation was the subcutaneous progesterone, the orange group, and it showed that there was improvement in the pregnancy rate, clinical pregnancy, or they corrected the lower pregnancy rate when adding supplementing the subcutaneous progesterone as regard the pregnancy rate, the clinical pregnancy rate, the ongoing pregnancy rate, and the live birth rate. transatlantic on the other way. In the States, they use the intramuscular progesterone. And this was a famous article. It was presented by Kate Devine in 2021. Infertility sterility. It included 1,060 frozen embryo transfer cycles, and the patients were randomized into 3 groups: the vaginal group only, the vaginal group plus intramuscular 50 milligram every 3 days, and intramuscular daily. And they found that the live birth rate was significantly lower in the women receiving only vaginal progesterone than women receiving intramuscular progesterone or combination treatment. And actually, the clinical pregnancy rate was similar, but the ongoing pregnancy rate and the live birth rate was lower in the vaginal group alone because the miscarriage rate was higher in this group. So supplementing the vaginal progesterone with intramuscular or using intramuscular progesterone has an effect on the miscarriage rate. Decreasing the miscarriage rate, you improve the ongoing pregnancy rate and improve the live birth rate. And the serum progesterone, when they measured the serum progesterone level in this frozen embryo transfer cycle, they found that the vaginal group has the lower mean serum progesterone level, about 7.6. The intramuscular group has the highest serum progesterone level, about 18. And the group with the vaginal intramuscular every 3 days has a mean of 11 or 12, which is adding the intramuscular or parenteral supplementation was higher, a mean level, than any lower level in the previous studies if you take the cutoff of 8 or 9 or 10. The same concept was also introduced in Europe, and this paper was published this year, 2022, in fertility sterility, and they supplemented not intramuscular, but the subcutaneous. In Europe, as I told before, use the subcutaneous. Patients with a lower level before the frozen embryo transfer, less than 9.2, they were supplemented by daily subcutaneous progesterone to compensate for this low level. And they found that the live birth rate, and this, as I told you, was called ILPS. Live birth rate was improved in the patients after adding the subcutaneous progesterone, similar to the patients with a high level of serum progesterone, 9.2. So they compensated the low level by supplementing the luteal phase with the parenteral progesterone, but here subcutaneous, not intramuscular, like the previous study from the States. And they concluded that individualized luteal phase support for patients with low serum level produces live birth rate similar to those patients with an adequate serum progesterone level. In June this year, 2022, this was an article by the French group, Charles Chaplin and Pietro Santulli, and the same effect, low serum progesterone affect the live birth rate in cryopreserved plus risk transfer cycle using HRT. Here the cutoff was 10. And last month in October, this was last month, in October 2022, a Turkish group in Istanbul, the same concept, and here they supplemented. They took the level of 10 and they supplemented the subcutaneous progesterone daily when the level was less than 10 to improve the pregnancy rate, and then concluded that the measurement of serum progesterone concentration on the embryo transfer day may create the opportunity for rescue progesterone administration on that day for patients who fail to reach an adequate serum progesterone concentration, achieving a similar pregnancy rate without cancellation of the cycles, and they supplemented here subcutaneous progesterone. So the level of serum progesterone, it seems to be of value, at least in the frozen embryo transfer cycle, as long as the trend is more towards frozen embryo transfer cycle. It's simple to apply this concept and to improve the pregnancy rate in these cycles by supplementing the patients in need by parenteral progesterone, whether intramuscular or subcutaneous progesterone. Progesterone is the mainstay in luteal phase support with early start to decrease the risk of miscarriage in selected cases. Vaginal and parenteral routes are the standard protocols till now. Serum progesterone level seems to have a role in the ongoing pregnancy rate. Intramuscular progesterone addition to the vaginal route seems to be beneficial as regards the clinical pregnancy rate and the ongoing pregnancy rate. I'm very honored to be presenting a talk of progesterone in front of the very eminent Professor Zirgel in this lecture. He was one of the pioneers in this progesterone supplementation retail talk. I'm very honored to be talking in front of him actually, and Professor Silber. And this will conclude my presentation about the serum progesterone. I'm sorry if it was prolonged in time.
Thank you very much, Professor Fahad. Very nice and nicely gathered.
And simple.
Nicely gathered, honestly, nicely compiled presentation. I just have, it's a combination of comment and question, actually. Well, it's good practice, apparently, that measuring serum progesterone is in many centers here in Egypt is taking place. However, when people find that the progesterone is low, they start supplementing by IM progesterone, but they forget about the pharmacokinetics and dynamics of this, and they give it every other day. Well, obviously, these fluctuating levels, because IM progesterone cannot stay in the system for that long if you give it every 48 hours. And this has been proven actually by a survey among doctors that has been performed on I think, 150 doctors in Egypt. So I think it's one of the things that we need to comment on or stress on as well is don't forget the basics. It's not giving it occasionally. You still have to follow the book whenever you give it. So I think it's worth mentioning as well. Yeah, Professor.
Thank you, sir, for this nice lecture. But there is a problem of the timing of measurement of progesterone, because if we need to give progesterone every 12 hours, at which hour you measure the level? Just before the next dose? And if you measure it, like if you give 8 a.m. and 8 p.m. and you measure progesterone at 7 p.m., how can you tell this level of...
Here it was...
Or it is multiple measurements?
It is single injection, intramuscular. Single injection.
So at the end of the time, every 12 hours...
The serum level of the serum progesterone, it actually doesn't go below, if you use the serum progesterone, it rises, it reaches maybe 30, 40.
If it does not
but
drop...
it doesn't fall below 10.
So why you need to give it every 12 hours if it
I
doesn't
didn't
drop?
say
Surely it does drop.
Hours. I didn't say every 12 hours.
No.
No, not in any papers. It's either daily. It's daily. It's daily. The subcutaneous is daily.
No, I am not talking about this. I'm talking about administration of progesterone in general. And some we give vaginal progesterone twice a day. If we give it twice a day, we understand that it should drop after like 10 hours or 12 hours.
If we use
and this is why we administrate another dose. Yeah, okay.
If I understood right, you were asking about when should we measure the serum progesterone. As far as I know, the consensus is mid-dose. So if you're taking 6 hours after, if you give, for example, progesterone suppositories that are supposed to be given every 12 hours, you measure after the third dose 6 hours after this, as far as I understand. Yes, but it's just the consensus that people thought, okay, this is our fixed point that we're going to compare people with as long as fixed. Obviously, yeah, just like any other medicine.
It is fluctuating, yes. They measured 1 hour, they're using every 12 hours the dose.
Yes, but the level you are measuring is fluctuating. So if you measure it at 8 p.m., it does not mean that this level at 6 p.m.
Correct, but here you actually the maximum, not more than 8 hours.
اوكي انا بس عندي سؤال يا دكتور فؤاد. انا لسه حد اجنبي موجود ولا I'm sorry انا كنت اتكلم بالعربي عشان there is a problem in the overuse of progesterone, not the proper use. In this country I have seen, and I can send you the prescriptions of 4 and sometimes 5 types of progesterone given at the same time, not by an ordinary practitioner, but by high profile reproductive. This is the first question. If there is any value of giving vaginal or rectal and oral and intramuscular, if there is any recommendations for that in literature? This is number one. Number two, the duration of therapy. And the UK practice is maximally 12 weeks. But in this country, I can tell you safely that at least it goes 37 weeks before delivery. So what is the proper academic teaching? Forget about the market. Forget about, but from your elegant lecture, I know it's essential, and we don't discuss that. It is essential for the maintenance and continuation of pregnancy. But for how long and in what proportion? Thank you.
The first question, the multiple combinations, oral, vaginal, intramuscular, there is no consensus for this, as you told. The combinations only, either vaginal intramuscular every other day, or vaginal and oral. Some do it, but not all. There is no consensus on this. As regard the duration, the paper I have shown about the questionnaire, 50% of the repliers, they told that they use progesterone up to 12 weeks. 35% told up to 8 weeks. If you go by evidence, there is no need for this, but this is what they actually do. No consensus for up to 36 and 37, except if there is a risk of something, preterm birth, repeated miscarriage or something. But 52% of the patients, of the clinicians that responded in the paper, they used progesterone supplementation up to 12 weeks.
Okay, yes, please.
So,
we'll take notes. Yeah, so I'll take on your next.
thank you for
So one,
this
two,
nice lecture. And regarding the phrase embryo transfer, the estimation of progesterone before this, there is a cut point between 10 and the ceiling is 20. If less than 10, you should postpone this for 2 days and give progesterone. But also, if more than 20, you should cancel the cycle and transfer after that. This is a ceiling, not absolutely more than 10.
I think the level is
not absolutely more than 10.
30. The high level of serum. I think.
The ceiling is 20.
I think it is 35 or 32 if the serum progesterone is very high. It's 33 or 34, not 20.
Now there is a ceiling 20. If more than 20, you should not transfer the embryo in this cycle.
So next question here, and then last question, and then we'll go on here. Okay. Okay, you're next, and then.
Is there any difference in dose and the duration in fresh cycle than the frozen cycle؟ يعني المفروض الفروزن سايكل بنتم ال 12 اسبوع فريش سايكل.
All the papers about the serum progesterone level were in the frozen cycle because there is no endogenous progesterone. Actually, you're measuring what you're giving. In the fresh cycles, there is endogenous progesterone level.
This about the duration, about the dose. There is any difference?
لا سؤال حضرتك يعني انت.
There is any difference in the dose and the duration.
In the dose, the standard dose they're using either 200 3 times or 400 vaginal or 400 twice. This is the standard vaginal dose. If you're supplementing with intramuscular, you can supplement with intramuscular, but if you're using only vaginal, it's 400 twice or 200 3 times. Or if you're using intramuscular only, it is 50 milligram, or sometimes use 100 milligram. In Egypt, it's only, the available up to now is 100. But some use 50 milligram, it's okay.
And the duration?
The duration is variable. There is no, the duration is up to 12, some use up to 12 weeks.
Okay. فرق بين الفريش والفروزن يعني.
هي
معلوماتنا ان الفروزن نطول شويه نخش على ال 12 لكن الفريش ممكن 8 10.
لا هي
You don't need to go further than this.
هي لغايه البلاسينتا
كمان المانوفر بتاع حكايه حقنه يوم ويوم وكل ثالث يوم الكلام ده
زي ما الدكتور عبد المجيد بيقول لغايه البلاسنتال شيفت.
Okay, so we'll take one last question.
اوكي شكرا.
يعني 8 اسابيع 8 اسابيع از لوجيك يعني اكتر من كده بقى يعني ما الموضوع مفتوح.
Is there any modification LUTL phase support in fed cycle in adenomyosis in progesterone dose?
I don't know. No.
Okay, thank you very much. Thank you, Professor Fahad. Thank you for the audience. Thank you, Professor Al-Majid. Thank you.
في اللي عاوز يقعد يا جماعه ياخد جايزه، هم هيوزعوا 3 جوائز دلوقتي. فاللي واثق من حظه يعني يقعد، واللي عارف ان حظه زينا كده هي كان ليف. اسحب اتفضل. حد من انا اللي اسحب يعني؟ اوكي. دكتورة نهلة خاطر. دكتورة يسرى العدل. يا عم انتوا جايبين اسامي وهمية، دي فيرشوال، اسامي فيرشوال كلها. دكتورة هدير عبد السلام. غالبا الفيميلز. دكتورة هدير. اوكي الحمد لله. خلاص اتفضلي يا دكتورة، الف مبروك. هم كلهم دكتورة فاتن عبد الله. ماشي ناخد يا عم صورة نخس عليها. اتفضل يا دكتورة فاتن. الف بص للصورة بس. اتفضل الف مبروك. فاضل واحد كمان عشان ما حدش يقول يعني.
يا رب يطلع راجل.
يا رب ولد يا رب. دكتور احمد الجندي. ده ايه ده احمد؟
دكتورة زينب جمال الدين.
دكتورة زينب جمال الدين.
أحمد فؤاد.
دكتور أحمد فؤاد موسى. يا عم قول الدكتور عبد المجيد ولا الدكتور حسام هتلاقيهم موجودين.
دكتورة مها فريد.
دكتورة مها فريد. دكتورة مها ده جاية قبل ما تسمع الاسم. لكن انت يا دكتورة مها جاية قبل ما تسمع الاسم صحيح. طب بص للصورة بقى. شكرا لشركة إفسا وشكرا للجميع.